Hi guys, welcome back to the Farre series. We started the Farre a couple of weeks back and we have already covered a few major systems from medicine. We have already done one session on the neurology. And in that session, we have discussed some of the important questions and the remaining questions we will be addressing today. So mainly we are looking at three questions. The first one will be related to the motor neuron diseases. The second one with respect to the stroke, and the other one on multiple sclerosis and other demyelinating disorders. That kind of covers all the major questions that can be asked from neuromedicine, right? So let me start with the first question. The first question goes like this: what are motor neuron diseases and describe amyotrophic lateral sclerosis? Now, this is not a very commonly asked question, but it's still possible because even the examiners are fatigued asking the same questions related to headache, stroke, migraine, the meningitis. So this is spanning little away from it. Okay, so what are motor neuron diseases? So let us begin by first giving you a definition. So motor neuron diseases refer to the diseases of the nervous system, of course, that are selectively targeting motor neurons. It's a very, very important concept to understand. For example, if I talk about meningitis, it is a disease affecting the meninges, right? Then if I talk about Brown-Séquard syndrome, it is disease affecting the spinal cord. If I talk about GB syndrome, it is disease affecting peripheral nerves. Now, yesterday or the previous session, we have discussed GB syndrome, and GB syndrome is a disease affecting peripheral nerves. We call it as infection triggered inflammatory polyneuropathy. So in GB syndrome, did it only affect the motor neurons? No, it affected all the components of the peripheral nerve. That means sensory, motor. That's why we had loss of sensations also as part of GB syndrome. And in fact, Miller-Fisher was a sensory predominant variant of GB syndrome. Then Aman was a motor predominant, right? So it did not selectively target motor neurons. If I have stroke, right, let us say there is a bleed in the brain, will it selectively target the motor neurons? No. All the structures that come in the vicinity of that blood will be damaged, be it sensory, motor, higher mental function neurons, they will be damaged. But if there is a disease which only affects the motor neurons, then we will call them as motor neuron diseases, right? So in the definition, we will make it clear that we know this essence. What is the motor neuron disease? It is these are the diseases selectively affecting motor neuron diseases are disorders selectively affecting motor neurons. Selectively affecting motor neurons. Now, what can selectively affect the motor neurons? Can stroke selectively affect the motor neurons? Not possible. Because let us say I cut the blood supply to some part of the brain, and that part may have motor, sensory, higher mental functions neurons and other neurons. And all the neurons in that area which was receiving the blood from this particular blocked blood vessel will be lost. If I cause bleed, it can't be selective. If I create a tumor, it can't be selective. So generally, what can cause a selective damage to motor neurons? Infections, toxins, and neurodegenerative disorders. Like if I have a toxin which only kills the motor neurons, then I can have selectively affecting motor neurons, right? So the classification wise, we will classify the motor neuron diseases into three broad groups. Whether the disease is only affecting upper motor neurons, whether the disease is only affecting lower motor neurons, or both. So we already know from our previous discussion that there are two levels of motor neurons. One bring the signal from the brain to the spinal cord, and then the other takes that signal from the spinal cord to the neuromuscular junction. So we have an upper motor neuron that brings the information from brain to spinal cord, and we have a lower motor neuron that brings the information from the spinal cord to neuromuscular junction. So lower motor neurons are there in the spinal cord and they go all the way to neuromuscular junction. Humans are there only in the brain, brainstem and spinal cord. I don't find them in the peripheral nerves, right? So diseases which only affect the upper motor neurons, the motor neuron diseases which only affect the lower motor neurons, and both being affected, right? That's the basic classification of motor neuron diseases. So MNDs will be classified as the diseases that selectively affect upper motor neurons. Those will be called as pure upper motor neuron type of motor neuron disease. Then we have pure lower motor neuron type of motor neuron disease, and then we have mixed motor neuron diseases. That means there is damage to both upper as well as lower motor neurons. damage to both upper as well as lower motor neurons. So let us begin by quoting some examples for the different types of MNDs. So for a pure upper motor neuron disease, a classical example is there is something called as primary lateral sclerosis. Lateral sclerosis. Now what is this? You know, when the motor neurons begin their journey from the brain and they go all the way to the spinal cord, they are part of a tract called as pyramidal tract, and this tract, because it decusates in the brainstem and then once it becomes part of the spinal cord, it's called as lateral corticospinal tract. Cortex to spinal cord, lateral corticospinal tract, which contains, of course, brain to spinal cord means upper motor neurons. So when these neurons die, we call it as primary lateral sclerosis. Why are we calling it as lateral? Because this tract is called as lateral corticospinal tract, and within that the upper motor neurons are dying, and the death or degeneration of neurons is what we are calling as sclerosis. So that is one classical example. Another classical example for the pure upper motor neuron MND, something that you study in PSM, it is called as, I'll give you a clue, can anybody tell me? It is due to a toxin called as beta oxalyl alanine amine, or BOA. Beta oxalyl alanine amine. Yes, it is letharism or neuroletharism. If you want, you can mention it is due to toxin beta oxalyl alanine amine from the contaminated dals. Okay. Next, pure lower motor neuron, we will quote two examples. The first one is called as spinal muscular atrophy. Spinal muscular atrophy. Remember yesterday when we discussed about LMN versus UMN damage, we learned that atrophy is a hallmark finding of damage to the lower motor neuron. And the moment I see that atrophy is being mentioned in the name, that I know it is a disease affecting lower motor neuron, right? Spinal muscular atrophy. This is a disease that typically affects the kids less than 3 years old. So we don't study in detail in medicine. It's something to be studied in pediatrics. Another disease that is a lower motor neuron disease, which I have seen plenty during my childhood, but your generation doesn't encounter much because India has successfully eliminated it, and that is poliomyelitis. So you might have seen polio affected individuals having severely atrophied lower limbs, because polio targets the cell bodies of lower motor neurons, and cell bodies of the lower motor neurons are sitting in the spinal cord. We call those as anterior horn cells, and because they are dying, the disease is also called as myelitis. Myel refers to spinal cord, itis means inflammation. Inflammation because of poliovirus infection, right? So these are two classical pure lower motor neuron type of motor neuron diseases. So when it comes to the mixed motor neuron diseases, actually there is only one that you need to remember, which is amyotrophic lateral sclerosis, or ALS. A disease that had affected a famous scientist and a personality called as, can anybody tell me who was affected with the amyotrophic lateral sclerosis, who was a big figure in the field of space research and science? Another one is a variation of this amyotrophic lateral sclerosis called as Madras motor neuron disease. Typically seen in southern part of India, not very common. It's considered as a variant of amyotrophic lateral sclerosis. Yes. Yes, Stephen Hawking was affected with the amyotrophic lateral sclerosis, and for you to write the answer for like the description of the amyotrophic lateral sclerosis, I just want you to remember the picture of Stephen Hawking that you saw on the social media or in the TV. Whenever you saw him, how did you see him? He was wheelchair bound. Number one, he was on a wheelchair. Number two, whenever he spoke, the sound was not natural. It felt like very machinery, artificial sound, because he was not able to produce voice. He had to take help of a artificial external device to produce voice, right? I want you to remember these two things. That's what we are writing in the answer. So now we know what is motor neuron disease and how are we classifying them. Let us begin by discussing in detail about amyotrophic lateral sclerosis, amyotrophic lateral sclerosis. So the first point I want you to write is that it is a mixed motor neuron disease. It's a mixed motor neuron disease affecting both UMN and LMN. Now tell me, will there be any loss of sensations in this patient? Of course not. It is a motor neuron disease. Only motor neurons are dying. There is no damage to sensory neurons, no damage to other neurons. So patient's only symptom is going to be motor deficits. Because motor neurons are damaged, patients will have difficulty to contract the muscles. Okay. Now why these motor neurons are dying? It is a neurodegenerative disorder. Now what do I mean by neurodegenerative disorders? The first example that should come to your mind when someone says neurodegenerative disorder is Alzheimer's disease. In Alzheimer's disease, the neurons of higher mental functions are dying, like the memory, behavior, they are dying. But why are they dying? What is the reason for the death of neurons in that case, Alzheimer's disease? Because neurons are developing abnormal inclusions. What were the inclusions in Alzheimer's disease? Amyloid beta and tau proteins. So if this is the neurodegenerative disorder, probably this is also because of developing abnormal inclusions. So what are those abnormal inclusions? It is believed to be due to inclusions mainly. One is called as TAR derived protein 43. The second one is ubiquitin immunoreactive proteins. Immunoreactive proteins. So these two inclusions, just like amyloid beta and tau, are responsible for Alzheimer's. These two inclusions are responsible for death of motor neurons. Now, why these inclusions are first of all appearing in the motor neurons? Do we know the reason? Well, we know the risk factors, not exactly the cause, but risk factors are known, just like Alzheimer's disease. In Alzheimer's disease also, we know the risk factors, why someone can develop Alzheimer's disease. So among the risk factors, age is a very strong risk factor. Age more than 50 years is a strong risk factor for all neurodegenerative disorders. That includes Alzheimer's, Parkinson's, and amyotrophic lateral sclerosis. Apart from that, genetics plays an important role. And when it comes to genetics, I want you to write two mutations. One is ORF gene mutation. If you forget this, it's okay. But there is one more mutation that I don't want you to forget. That is superoxide dismutase gene. Superoxide dismutase 1 gene mutation. Why? Because later on, while writing the management, we will be talking about the superoxide dismutase 1 again. So I want you to remember this. Your examiners are also specifically looking for this mutation. Okay, so the amyotrophy is another word for atrophy. So it's okay. It's a beautiful thing in medicine that names give a lot of information about the diseases. So the name of the disease is amyotrophic lateral sclerosis. So on one side, we're talking about the muscle atrophy. Second side, we're talking about lateral sclerosis, and the word lateral here refers to lateral corticospinal tract. So you're having atrophy of the muscles and you have evidence of dysfunction or damage of lateral corticospinal tract. And lateral corticospinal tract contains upper motor neurons. And atrophy happens because of lower motor neuron damage. So in the name of the disease itself, information is there to say that there is damage to both upper as well as lower motor neurons. And sclerosis is a word used for damage to the structures. It could be because of fibrosis, right, or degeneration. When some structure gets damaged, we can use the term sclerosis. Okay, so these are the important risk factors. Stephen Hawking was kind of an exception because he got the amyotrophic lateral sclerosis quite early in his life, not after 50 years of age. So he was an exception on several grounds, right? He had exceptionally high IQ. He was a different person. But otherwise, the most cases of ALS that you are going to see are past 50, and they may be having one of these genetic mutations. Now, how these patients are going to present? Because their upper and lower motor neurons start degenerating one by one. They start losing the upper and lower motor neurons. Now, let us say, okay, I'm looking at a person and his upper motor neuron, which was supposed to take the signal to the biceps muscle, is dead. Like this neuron, got degenerated because it developed the accumulation of TDP43, ubiquitin immunoreactive proteins, and it eventually died. Now, will he be able to contract his biceps? Upper motor neuron is gone. So that he wants to contract the biceps, will he be able to contract? No. The signal originating from the motor area can't reach the lower motor neuron at all because the carrier neuron is dead. Okay. So now the first thing he will notice is that he is not able to flex the elbow. Flexion of the elbow is function of the biceps muscle. Okay. Now after few days, what happens is, because the disease process continues and there is continuous accumulation of these abnormal inclusions, the other neurons also start dying. So after a few days, the lower motor neuron, let us say of triceps, dies. Now what will happen to him? Will he be able to extend the elbow? Earlier he was not able to flex the elbow because the biceps was, like the nerve supply to the biceps was degenerated at UMN level. Now at the LMN of triceps is gone. Will he be able to extend the elbow? No. Now what happened? Neither he can flex the elbow nor he can extend the elbow. After a few days, the upper motor or the lower motor neuron of another muscle will die. So eventually what happens? Slowly, one by one, muscle start losing the control. So progressively he starts losing control of the limbs, right? So one of the clinical feature we are going to present is progressive limb weakness. Now in this example that we are looking at, biceps has lost its UMN, triceps has lost its LMN, both are weak. But when I examine, what will I find? If I check the tone and reflex of biceps, what will happen to tone and reflexes in the biceps? Its UMN is gone. So when UMN damage happens, what happens to the tone? Remember, in UMN damage, everything goes up. Tone increases, reflexes increase. So biceps tone will be increased, biceps reflex will be exaggerated. Biceps jerk, as we call it, will be exaggerated. But if I do that for the triceps, what will happen to the triceps? Triceps has lost its lower motor neuron. Its upper motor neuron is fine. So then the triceps will be weak, its tone decrease, reflexes diminished. So in a same individual, I'm finding that some muscles who have lost their UMN, their tone and reflexes are exaggerated, and some muscles who have lost their LMN, their tone and reflexes are diminished. Sutapa, why we get progressive limb weakness? Because it's a neurodegenerative disorder. Means slowly in all neurons, these substances start accumulating. Motor neurons, it's a pure motor neuron disease. So these substances start accumulating, and as they accumulate, the body starts destroying those neurons. So one by one, neurons start dying, the motor neurons. So some muscles, upper motor neurons die first. For some muscles, their lower motor neurons die first, but one by one, motor neurons keep dying. And whichever muscle loses their upper or lower motor neuron cannot now function because the signal from the brain cannot reach the muscle. So that muscle becomes weak. So it might start in any group of muscles, but once it is started, right, one after the other, the muscles keep losing their upper or lower motor neuron. They start becoming dysfunctional. So over time, more and more muscles start becoming dysfunctional. So progressively, their limbs start becoming weak. So in this example that I gave, this person was earlier not able to flex the elbow because biceps had lost UMN. After a few days, triceps lost its element. Now he can't extend the elbow also. So neither flexion is possible, extension is possible. After a few days, he might lose UMN or the element of the flexors of forearm. So then he can't flex the forearm. Maybe eventually he will lose the UMN or element of extensors of forearm. Now he can't extend the wrist. So eventually the limb will become even and more weak because he starts losing the muscle functions. So that's why the first complaint you are going to write is progressive muscle weakness. And extra thing I want you to add is, because it's not like your other stroke or other cases where either UMN or LMN are damaged. Here both are affected, but for some muscles UMN is damaged, for some muscles LMN is damaged. So when you examine, you will see some muscles showing LMN signs, some muscles showing UMN signs, and that's what examiners are looking for. You should specifically mention that you will have progressive limb weakness with some muscles showing LMN findings and some muscles showing UMN findings, with few muscles showing LMN and few showing UMN findings. Even for an MCQ based exam, if there's a question talking about like atrophy, fasciculations, areflexia in some muscles and spasticity, hyperreflexia in some muscles, for all practical purpose, the question is about amyotrophic lateral sclerosis. So this is the first thing that I want you to write. Second thing, so this explains why Stephen Hawking was wheelchair bound, because progressively he was losing control over the muscles because his upper or lower motor neurons of individual muscles were losing their function, right? But then why was he not able to have a good speech? Why he had to depend on the machine? Now don't say, sir, it is because of the weakness of muscles involved in speech. Yes, it is because of the weakness of muscles involved in the speech. But how do we control the muscles involved in the speech? See, what is speech? Speech is basically an expiration. See, when the patient presents Uthappa at the early stage, he may only present with weakness of some body part. Like if flexors of the forearm have lost their upper or lower motor neuron, he might only have a complaint of inability to flex the wrist. So many times at the early stages, the disease may get missed, but as multiple regions get involved, the disease becomes clearly evident. Well, okay, I was talking about speech, right? Speech is basically an expiration. So when I'm talking, I'm exhaling air out from my lungs, and as the air comes to my vocal cords, the vocal cords vibrate to produce the sound. So vocal cord vibration is required for production of speech. And how is it controlled? How that vibration is controlled? Through recurrent laryngeal nerve, which is a branch of vagus nerve. So can I say that cranial nerves are controlling the vocal cord movement? Yes. Okay, and if they're controlling the vocal cord movement through muscles, so the neurons that are involved, they will be called as motor neurons, right? Because muscle control. Now, once the voice is produced by the vocal cords, do we throw the same voice out to the listeners? No, we modulate that voice. How do we modulate? We still contract our pharyngeal and oral muscles, including tongue, to create a different sound out of that sound produced by the vocal cord. For example, if I have to say "her," I have to touch my lips. If I don't touch my lips, I can't produce that sound. So the sound produced by the vocal cord is different. It is modulated as we throw that sound out. The modulation happens in the oropharynx and oral cavity with the help of tongue, soft palate, pharyngeal muscles. And how do we control the tongue movement? Hypoglossal nerve, iono-cranial nerve. How do we control the glossopharyngeal muscles? I mean the muscles in the pharynx, glossopharyngeal nerve and vagus nerve. So basically, first voice is produced by vocal cord, that is called as phonation, and then it is modulated as the sound travels through the throat, mouth and nose. That modulation is called as articulation. So finally the sound that comes out from my mouth is phonated and then articulated, and all of these are controlled by cranial nerves like hypoglossal nerve, glossopharyngeal nerve, vagus nerve. All are cranial nerves, and it's all about movement of muscle. So the muscle movement is carried out by motor neurons. So if the motor neurons in the cranial nerve get damaged, I can have impairment in my speech. And we will call this phenomenon as bulbar or pseudobulbar palsy. Now I will try to tell you what this pseudobulbar or bulbar stands for. So we all know that we have something called as brainstem. We have midbrain, pons and medulla. This is our brainstem, and the cranial nerves have their nuclei in the brainstem. Like let us say I'm talking about vagus nerve nucleus, which is concerned with the vocal cord movement. So cranial nerve 10, let us say this is cranial nerve 10th nuclei, vagus nerve nuclei. So this contains a cell body for the vagus nerve, 10th cranial nerve. Cell body is there in this nuclei. But do I control my vocal cord movements or what I want to say directly from the brainstem, or higher brain has a control? I should say only what my mind and heart wants to speak out, right? I can't say that, no, I didn't want to say that, but it just came out from my mouth because my brainstem fired. No, that does not happen. So we always have a higher control. So there is a higher control from the motor area of the brain. So this motor area of the brain, we have a neuron, a set of neurons which bring the signal from the brain to the brainstem. We will count them as upper motor neurons for the cranial nerves, and the lower motor neurons for the cranial nerves begin their journey from the brainstem and go all the way to the concerned muscles. So it is similar to the pyramidal tract, right? Pyramidal tract brings the motor neurons from the brain to spinal cord. From the spinal cord, we have lower motor neurons going to the muscle through spinal nerves. Now, for the cranial nerves, we have an upper motor neuron coming from the brain to the brainstem, and lower motor neuron originating in the brainstem going to the muscle. And this pathway that brings the upper motor neurons from the brain to the brainstem, we will call this pathway as, corticobulbar tract. Why am I calling it as corticobulbar tract? Because this brainstem, particularly medulla, when seen from behind, it looks like a old generation 60 watt, 100 watt bulb. It kind of looks like that bulb. That's why the brainstem can be referred as bulb, particularly with reference to medulla. So it is beginning, this tract is beginning its journey in the cortex of the brain, coming to the medulla, that is bulb. So that's why we call it as corticobulbar tract. So UMNs for cranial nerves are there in the corticobulbar tract, and elements in the cranial nerves, and they can also lose the function because this TDP43 and ubiquitin immunoreactive protein, they are all accumulating in these as well, and because of that the cranial nerves also lose their upper or lower motor neurons, and then the muscles controlled by cranial nerves lose the function. Let us say the UMN of this 10th cranial nerve died in the corticobulbar tract. So now LMN can't get any signal from the brain. So can the vagus nerve control the vocal cord movement? No. The vocal cord movement is lost. And if the vocal cord movement is lost, I can't produce the voice. The phonation is gone. Right? Let us say, if that is fine, I have done the damage to hypoglossal nerve, lower motor neuron. Because hypoglossal nerve, lower motor neuron is damaged, now the phonation may happen from the 10th cranial nerve. I may be able to produce the voice, but then tongue movement, whatever modulation of sound I do because of tongue movement, that will be lost. So articulation will be lost. So one of the two things happen, either phonation gets affected or articulation gets affected, or both. If all these neurons are damaged, then both get affected, right? So we will call this damage to UMN or LMN as bulbar or pseudobulbar palsy. Now what is the difference between bulbar or pseudobulbar palsy? Because we are calling brainstem as bulb, so if the damage happens to the lower motor neurons, then we will call it as bulbar palsy. But if instead of lower motor neuron, it is the upper motor neuron in the corticobulbar tract gets affected, then we will call it as pseudobulbar, because at the level of bulb there is no problem. It is above the bulb where the problem is there, right? Okay, now for the exam, you're not expected to write the bulbar versus pseudobulbar palsy. What teachers want you to mention is what are the findings. And remember, when we're talking about bulbar or pseudobulbar palsy, bulbar is lower motor neurons of the cranial nerve affected, pseudobulbar is upper motor neurons of the cranial nerve affected. And regardless of whether upper or lower motor neurons affected, the concerned muscles regulated by the cranial nerves lose the function, and main concern is about the brainstem. So when brainstem, especially medulla, their cranial nuclei or their upper motor neurons die, one of the outcome is dysphonia. Why am I getting dysphonia? Because I am losing the vocal cord control, and vocal cord control is required for production of sound or phonation. After that, if hypoglossal, glossopharyngeal and vagus nerve get damaged, I may also develop something called as dysarthria. What is dysarthria? Dysarthria refers to impaired articulation. Articulation is the modulation of sound produced by the vocal cords at the level of nose, throat and oral cavity. So they get affected. And you may also get one more manifestation because of this bulbar or pseudobulbar palsy, and that is dysphagia. Why am I getting dysphagia here? Dysphagia is impaired swallowing or difficulty in swallowing. Why is that appearing? Because the act of swallowing needs help of cranial nerves. I have to chew, create a bolus, and then that bolus has to be pushed from the mouth to the pharynx. How do we push? Tongue. Who is regulating? Hypoglossal nerve. Once it goes to the pharynx, it has to be pushed down, right? Who is doing that? Pharyngeal muscles, controlled by glossopharyngeal and vagus nerve. After that, epiglottis has to close the trachea. So all these movements are regulated by the cranial nerves originating in the medulla. And if they are dysfunctional, I will not be able to do this task, right? So I can develop dysphagia. So what is the story of this amyotrophic lateral sclerosis? Limbs become progressively weak. That's why the person may become wheelchair bound. And then because upper or lower motor neurons in the cranial nerves also die, they may end up developing dysphonia, dysarthria, dysphagia, the classical 3D symptoms. And these 3D symptoms were there in Stephen Hawking. That's why he could not produce a proper voice. He had to take help of a artificial voice synthesizer machine to communicate with the external world, right? And this bulbar or pseudobulbar palsy is one of the important reason for death in patients with amyotrophic lateral sclerosis. Why? Because if I'm not able to swallow properly, if I can't direct the food to go into the esophagus only, the food may land in the trachea, and if it goes into the trachea, we develop aspiration pneumonia, and that can become one of the reason for death. So there are two causes for death in these patients. One, the progressive weakness of muscles eventually also causes paralysis of respiratory muscles. So you can develop respiratory failure and die, or you can aspirate the food and die. So that also we will mention in our answer. So these are the symptoms that we are expecting and causes of death for these patients. One of them is respiratory failure, and the second one is aspiration pneumonia. These are the common causes of death. Okay, so now that we know the findings, we know the cause, let me quickly summarize it. So what are motor neuron diseases? These are the disorders that only affect the motor neurons, not the other neurons. No sensory neuron involvement, ideally no higher mental function neurons involvement. The motor neuron diseases are classified based on whether only upper motor neurons get affected or only lower motor neurons get affected or both. Only upper motor neurons getting affected, classical examples are PLS and lathyrism. Only LMN getting affected, classical examples are spinal muscular atrophy and poliomyelitis. Both getting affected, a classical example is amyotrophic lateral sclerosis. ALS is our main question. So it is an MND affecting both UMN and LMN. And the reason why UMN and LMN are dying is these are neurodegenerative disorder. That means accumulation of some substances becomes the reason for death of neurons. And those substances are TDP43 and ubiquitin immunoreactive proteins. Why are they accumulating? Right now we don't know. We only know that it is typically more common in elderly, and people with ORF or superoxide dismutase 1 mutation carry the higher risk of developing amyotrophic lateral sclerosis. Once the disease starts, upper and lower motor neurons start dying one by one, and because of that, patients start developing progressive limb weakness. And when we examine the weak limbs, some muscles will show that their upper motor neurons are dysfunctional. That means they will have increased tone and increased reflexes. And some muscles will show that their lower motor neurons are dysfunctional, showing decreased tone and absent or diminished reflexes. Along with the progressive limb weakness, because cranial nerves also lose UMN or LMN, we end up with the 3D symptom, that is dysphonia, dysarthria and dysphagia, and we call this as bulbar or pseudobulbar palsy. So progressive limb weakness plus bulbar or pseudobulbar palsy is equal to amyotrophic lateral sclerosis. Now that we know the clinical features, let us talk about its diagnosis. How do we diagnose ALS? So for the diagnosis of ALS, we follow something called as Escorial criteria. Escorial criteria. So what we have done in this criteria is the body, human body is divided into regions. So please try to understand what we are talking here. Human body is divided into regions based on the nerve supply. And then we will see in how many regions there is weakness and UMN and LMN involvement findings. So the first region is bulbar region. The head and neck region is called as bulbar region. Why are we calling head and neck region as bulbar region? Because the control of head and neck, like if you want to wink, right, If you want to move your tongue, how are you controlling it? Winking, cranial nerves, facial movement, cranial nerves, tongue movement, cranial nerves, right? So head and neck region movement is controlled by cranial nerves, and cranial nerves originate where? Brainstem. Brainstem is bulb. So that's why this is called as bulbar region. And then both the upper limbs, we will call it as upper limbs, we are calling them as cervical region. Why are we calling it as cervical region? Because the nerve supply to upper limb comes from brachial plexus, right? It's as simple as that. And brachial plexus, you know, it is formed by C5 to T1 spinal nerve roots. So mainly you can say that the nerve supply to upper limb is coming from cervical segment of the spinal cord. That's why we're calling it as cervical region. Then the thorax and the abdomen is called as thoracic region. Why? Because the nerve supply to this region comes from the thoracic segments of the spinal cord. So this will be called as thoracic region. And then the lower limb, we are going to call it as lumbosacral region. Why? Because the nerve supply to the lower limb mainly comes from lumbar plexus and these some other neurons originating from the sacral region. So that's why the lower limb will be called as lumbosacral region. So among these regions, if you find that weakness is present in at least 3 regions and each region has evidence of UMN involvement, that is hyperreflexia and spasticity, and LMN involvement, that is hyporeflexia and the flaccidity or decreased tone, then the diagnosis is certain that you are having amyotrophic lateral sclerosis. So if you get UMN plus LMN findings in more than or equal to 3 regions, that is equal to definitive ALS according to the Escorial criteria, right? Now let me try to make you understand what is the meaning of this statement, UMN plus LMN findings in more than or equal to 3 regions. Okay, so let us say the right upper limb is one cervical region, left upper limb is another cervical region. So there are 2 regions now, and plus let us say right lower limb, that is a one lumbosacral region. Now I examined and this patient had weakness of right upper limb, left upper limb and right lower limb. 3 regions are showing weakness. And when I examine in the right upper limb, I noticed that triceps is showing increased tone and increased reflexes. That means triceps is having involvement of upper motor neuron. And when I checked the biceps shows absent reflexes and decreased tone. That means biceps has lost LMN. So in each region, like in this region itself, I have LMN plus UMN involvement, right? Similarly, I also examined the right lower limb, and in the right lower limb, let us say quadriceps or quads are showing increased tone and reflexes. That means UMN is damaged for quadriceps. But when I check the hamstring group of muscles, I noticed that the tone and reflex are diminished. That means LMN is affected for the hamstrings. So in the same region, that is right lumbosacral region, I have LMN plus UMN. So in each region that we are considering here, if you get evidence of LMN plus UMN involvement and you find 3 such regions, then you can call it as amyotrophic lateral sclerosis according to Escorial criteria. Right? Is that clear? A crazy loser, sure. We'll cover the Parkinson and Alzheimer's as well. So this is the criteria. Point to remember is we are following a criteria called Escorial. Create a beautiful picture of human body and label the regions for the teachers to know that you know the essence of this criteria. And then once that is done, you have to mention that you should have LMN plus UMN findings in each region for 3 such regions to call it as clinically definite ALS. Now, once we have learned about the diagnosis, the last bit is how are we going to manage. And in the management, the first statement I want you to mention is the prognosis of ALS is poor. Why is it poor? Because eventually you will develop respiratory muscle paralysis and you can die because of that. Or if not, you will die because of the aspiration pneumonia. So progression Prognosis is poor, in fact very poor. The median survival, how long a person of ALS survive after development of bulbar or pseudobulbar palsy. Median survival after bulbar or pseudobulbar palsy. What are the symptoms of bulbar or pseudobulbar palsy? You will end up with dysphagia, dysphonia, dysarthria, and this dysphagia becomes a risk factor for aspiration. Is approximately 3 months. Means once you develop bulbar or pseudobulbar palsy, 3 years. So you barely survive for 3 years, not beyond that. In fact, most of the patients die quite early, within months of developing bulbar or pseudobulbar palsy. So that's why the main goal of management is to minimize the risk of death. All those limbs which are weak now, can they be recovered? The answer is no, because it's not about muscle strength loss, right? It's the neurons connecting the brain to muscles are dead, and the dead neurons cannot be revived. So all we can do is try to protect the remaining neurons from dying and preventing the aspiration pneumonia so that you don't die because of that. So that's why the supportive care plays more important role than medications per se, because majority of them are going to die because of this aspiration pneumonia. So what all supportive care I can do? First thing I want you to write about is the minimizing the risk of aspiration pneumonia. How can we minimize risk of aspiration pneumonia? See, this patient can't swallow properly because he has lost the control of the swallowing muscles. So once he tries to eat, the food goes into his mouth. Only God knows whether the food will land in the esophagus or it will land in the trachea and go to the lungs and cause aspiration pneumonia. So what can I do for that? Means median survival refers to how many years on an average these people can live after the diagnosis of bulbar or pseudobulbar palsy. See, if food goes to the mouth, then as I've already told you, they can't control the coordinated movement of the food bolus to reach the esophagus, so it may land anywhere, can cause aspiration pneumonia and die. But what if I bypass the food from mouth directly to the stomach or the intestine? Then the chance of aspiration is minimized, right? How can I bypass? One of them is putting the nasogastric tube or Ryle's tube, but it is a short-term solution, not a long-term solution. The best long-term solution is connect a tube directly to the stomach and put the food into that stomach directly. We will call it as gastrostomy. Gastrostomy refers to a tube directly connected to the stomach and food is directly added to it. Now it is done semi-invasively with the help of endoscopy, so it's also called as PEG tube, percutaneous endoscopic gastrostomy, right? So that minimizes the risk of aspiration. So Stephen Hawking did not develop aspiration because he had undergone gastrostomy. Okay, then he was taking the help of a artificial machine to produce voice because he had dysphonia, dysarthria. So for that we can use a device called as voice synthesizer. Third, because their limbs are progressively weak, they might require wheelchair or other mobility assistance. So these are the components of supportive care. There is risk of aspiration, so we do gastrostomy. They have difficulty producing voice and modulating it, so we can provide them voice synthesizer machine. And they have limb weakness, to help them mobilize themselves, we can put them on wheelchair or other mobility assist devices. Okay, then coming to the pharmacotherapy. Okay, this is supportive care, but can I do something to prevent the progressive death of neurons that is happening in them? Well, we had two neuroprotective agents that were used traditionally for quite some time. One of them is riluzole and the second one is edaravone and riluzole. These are neuroprotective agents, so they stop the remaining unaffected neurons from dying. So at least the disease won't progress. But are they really effective? The answer is no. To some extent they are effective. These neuroprotective agents, studies have shown that they increase life expectancy by around 3 months. So it's not great. By around 3 months means they were likely to die by 3 years. If not treated, you treat them, you make them live 3 months more. Nothing great. But is there anything hopeful for near future? Yes, we have a new drug recently approved just a couple of years back. which is called as tofersen. Tofersen is for ALS patients. It's a gene modifying therapy. ALS patients with superoxide dismutase 1 mutation. So it's not for all ALS patients. It is only for those ALS patients who have mutation in SOD1. It is a antisense oligonucleotide modulating the expression of superoxide dismutase 1. If you don't have this mutation, this drug is of no use for that patient. Okay. This is bringing some hope to the management of ALS, hoping that it will extend the life expectancy significantly compared to not so effective earlier drugs, right? So 3 things you need to write: riluzole, edaravone, and tofersen. And with that, we complete our discussion on the motor neuron diseases with a special reference to amyotrophic lateral sclerosis. Okay. Now let's go to the next question. The next question is on the demyelinating disorders of the central nervous system. So they may ask you to list the demyelinating disorders of the CNS, and then they may ask you to write a main question on either multiple sclerosis or neuromyelitis optica. In all probability, the question will be on the multiple sclerosis. Okay, so what is this multiple sclerosis? So the dysphonia and dysphagia are because the act of swallowing and the act of producing the voice is all controlled by cranial nerves, and swallowing is movement of muscles, voice production is movement of muscles. So the cranial nerve neurons which are involved in movement of the swallowing muscles or movement of speech muscles, they are all motor neurons, and in motor neuron diseases they can also get affected. So if the TDP43, ubiquitin immunoreactive proteins, they accumulate in the motor neurons of cranial nerves, they will also die, and once they are dead, you will have difficulty to control the vocal cord movement, so you will not have proper voice production. That is dysphonia. You will not have a control of tongue muscles, pharyngeal muscles to push the food directly into the esophagus and not into the trachea. So you lose that control. That will cause dysphagia. Okay, so what are these demyelinating disorders of CNS? So yesterday we studied about GB syndrome, and in GB syndrome we learned that there is either damage to myelin or axons. Myelin damage, we call it as demyelination. So we can say that the AIDP variant of GB syndrome is a classical example for demyelinating disorder of the peripheral nervous system. But then we also have a central nervous system, brain and spinal cord. There also myelin exists, and I can cause the damage to myelin sheath there as well. So when they get damaged, we will call it as demyelinating disorder of CNS. So what are the demyelinating disorders of CNS? The demyelinating disorders of CNS, among them, the most common one is multiple sclerosis. Demyelinating disorders of CNS. The most common is multiple sclerosis. Apart from that, we have this so-called neuromyelitis optica, usually abbreviated as NMO. Then we have another called as myelin oligodendrocyte glycoprotein antibody disorders. Myelin oligodendrocyte glycoprotein myelin oligodendrocyte glycoprotein antibody disorder, or in simple words, MOG disorder. This is called as MOG disorder. So these are common. Apart from that, you have acute disseminated encephalomyelitis, ADEM, acute disseminated encephalomyelitis. These are demyelinating disorders of the central nervous system, right? So first let us talk about multiple sclerosis. Why gastrostomy is needed? Simple. The dysphagia becomes a reason for aspiration. Why? Because if I struggle to swallow and direct the food into the esophagus, the food may go into the trachea, and that can become a reason for death. So I don't want this to happen. And the only way I can avoid the food going into trachea is by bypassing the food directly to the stomach instead of trying to pass it through the pharynx. If it is passing through the pharynx, then I need a coordinated control of muscles to push the food into the esophagus and not to go into the trachea. I'm not able to do that for the patient because patient's cranial nerves are dysfunctional. So the best way is I should directly put the food into the stomach. So if the food goes into the stomach directly, then there is no risk of aspiration at all. That's why we are doing gastrostomy. Okay, so multiple sclerosis. What is it? First point I want you to write is, it is the demyelinating disorder of CNS. Demyelinating disorder of central nervous system. Why the CNS neurons are getting demyelinated? It is an autoimmune disorder. It's an autoimmune disorder. And if it is an autoimmune disorder, is it cell mediated immunity which is responsible, or is it antibody mediated? Well, it is both. There is cell mediated damage as well as antibody mediated. And if it is antibody mediated, of course there comes a question, which antibodies are responsible? So the most common antibody responsible for causing the damage to myelin sheath in these patients is anti-myelin basic protein antibody. So there is a protein in myelin sheath called as myelin basic protein, or MBP, and against that antibodies are produced, and because of that the myelin sheath start getting damaged. And the cell mediated immunity also targets the myelin producing cells, that is oligodendrocytes. So oligodendrocytes get damaged, as well as the myelin sheath directly gets damaged by this anti-myelin basic protein antibody. This is the most common antibody. We do get other antibodies as well. Now, do we know the cause for this disease? Well, we don't know the cause, why these antibodies are getting formed and why the patient is developing this multiple sclerosis. All we know is risk factors, and being an autoimmune disorder, this is more common in females than males, with a ratio of almost 4:1. For that matter, we know that majority of autoimmune disorders are more common in females than males. Other risk factor well established is vitamin D deficiency. In fact, when I was an undergraduate student, we barely spoke about multiple sclerosis. It was an irrelevant disease for our country, or at least we thought so. But with time, the cases of multiple sclerosis are increasingly being diagnosed in India as well. And there are two possibilities for it. One, increased awareness among doctors. So we are picking up these cases. Earlier, probably we may be missing them. Second, there is a rise in the vitamin D deficiency in Indian population. So that also explains. Okay. Apart from that, Epstein-Barr virus infection. In fact, any autoimmune disorder, if you are not fully prepared, no, you can write vitamin D deficiency and Epstein-Barr virus infection among risk factors. Like with closed eyes, mostly your teachers will accept it. Okay, so these are the risk factors I want you to write. Okay, so Tapa, that's a area of ongoing research. So there are a lot of factors which are responsible. It is multifactorial and bit complex. So maybe we'll discuss that some other day when we take up the autoimmune disorders in detail. Okay, so these are the risk factors. Now, if someone develops it, there is damage to the myelin sheath, and they will present with multiple sclerosis. So what clinical features they are going to bring to the hospital? So what is going to be the presentation of a patient with multiple sclerosis? So point to note here is, I forgot to mention, it's a demyelinating disorder of CNS characterized by recurrent attacks of demyelination. Recurrent attacks of demyelination. So that means I'll get demyelinating attacks again and again. So it's a chronic disease. It's not like, okay, it happens once and then it's like sorted. No. The best way to understand this disease is compare it with alopecia areata. In your dermat classes, sir might have taught you about alopecia areata. So what is this alopecia areata? It's a condition where, again, it's the same autoimmune disorder. Alopecia areata is also an autoimmune disorder. So where our T cells target our hair follicles and then start causing the damage. So we start losing the hair follicles. And how does it present? It presents as a coin-like patchy loss of hair. So if I see a patient of alopecia areata, so he has hair everywhere, but in one region there is coin-like patchy loss of hair. Everywhere else there is hair, but there is one small region where he has lost the hair. That is an alopecia areata patch. If you treat or not treat, many of them recover. So this area will eventually develop hair growth, most cases. But after a few days, he will present again with hair loss in some other area. There will be a new patch appearing. So what happened now? The alopecia areata recurred again. So the earlier area we recovered, new area hair lost. Treat or not treat, this also may recover, but after a few months he might develop another area with another patch. So it's a recurrent disease. Exactly same happens with multiple sclerosis. So let us say today I have demyelination of spinal cord. Demyelination of central nervous system means brain and spinal cord. So today I have demyelination of spinal cord. I will have symptoms related to that. I may recover from it because myelin damaged, eventually remyelination happens. I may recover from that. But after a few months, I may develop demyelination of cerebellum. After a few months, I may develop demyelination of maybe another part of the brain. So recurrently different areas of the brain keep getting affected by demyelination. So symptoms are not going to be constant. Like every time I will present with same symptom, no. It will depend on which part of the central nervous system got demyelinated. So when cerebellum got demyelinated, I will present with ataxia, nystagmus, dysdiadochokinesis, all of those symptoms. If spinal cord got demyelinated, it depends on whether the pyramidal tract got demyelinated or sensory tract got demyelinated. If sensory tract got demyelinated, I present with loss of sensations. If pyramidal tract, which contains UMN, they got demyelinated, I present with weakness. So presentation is not constant. It depends on the structure that got demyelinated, right? It's just like alopecia areata. So sometimes I may have a alopecia areata patch in the beard, sometimes in the scalp, right? Sometimes on some other body part. So when I present, oh, this time it is the chest hair, I have a patch. Next time on the forearm, I have a patch. Next time in the beard, I have a patch. Next time I have a patch in the scalp. So it keeps changing. So same with multiple sclerosis. The symptoms are not constant. So first statement you have to write is patients present with recurrent demyelination and clinical features depend on site of demyelination. And that of course begs a question. What is the most commonly affected site? The most commonly affected site of demyelination is going to be spinal cord. Spinal cord most commonly gets demyelinated. And if spinal cord is most commonly getting demyelinated, which part of the spinal cord? Because spinal cord has ascending tracts, descending tracts, central gray matter, what gets affected? So within the spinal cord, sensory tracts are most commonly affected. So what symptoms this will lead to if the sensory tracts get affected? Loss of sensations and development of paresthesias. Paresthesia means tingling sensation, numbness, pins and needle sensations. These are the common symptoms that these patients present to hospital with. How commonly spinal cord gets affected? It gets affected in more than 2/3 of cases. So if I keep seeing multiple sclerosis patients, right, 60% of them are coming to me because they have lost sensation in some part of the body part. And when we investigate and evaluate, we get to know that in the spinal cord, sensory tract is demyelinated because of this antibody and cell mediated injury. The second most commonly affected site after this spinal cord is optic nerve. Optic nerve is the second most commonly affected structure. So optic nerve gets demyelinated, usually unilateral. So one optic nerve gets demyelinated. And what it will lead to, if the optic nerve gets demyelinated, I will have difficulty to see from that eye. So I may present with monoocular, means single eye vision loss. Monoocular vision loss. Okay. What other structures can get affected by demyelination? Other structures that can get affected include cerebellum. And if cerebellum gets demyelinated, what symptoms we are expecting? It leads to ataxia, then nystagmus, and action or intention tremor. Action tremor or intention tremor. Okay, you can also have demyelination of the motor tract, that is your pyramidal tract, And if pyramidal tract get demyelinated, you can have motor weakness or paralysis of the muscles. You can also have demyelination of the brainstem, and we just learned that brainstem contains the cranial nerve nuclei. So we can also develop cranial nerve palsies because of the demyelination of brainstem. So these are all manifestations they can present with. So among these, which symptom they come to hospital with depends on which structure is demyelinated. If cerebellum gets demyelinated, these are the symptoms they will bring. If motor tract get demyelinated, they come with weakness. If brainstem gets demyelinated, they come with cranial nerve palsies. If spinal cord get demyelinated, mostly they present with loss of sensations and paresthesia. If optic nerve get demyelinated, they present with one eye vision loss. So these are going to be their symptoms. Okay. Now, can I diagnose the multiple sclerosis just based on the clinical features? Absolutely impossible, because from the clinical examination or history, you can only identify which part of the central nervous system is affected by this disease. Like if I present with dysdiadochokinesis, intention tremor, ataxia, then you know cerebellum is damaged. Whether it is because of an infarction, whether it is because of a tumor, whether it is because of an infection, or whether it is because of alcohol or multiple sclerosis, only investigation will tell you, right? Can I diagnose it without investigation? No, impossible. But there can be some clinical clues which point highly towards multiple sclerosis. That does not mean that presence of these symptoms always are diagnostic of multiple sclerosis, but they can be potential clues towards multiple sclerosis. We will call these symptoms as ancillary symptoms, which are highly suggestive but not diagnostic of multiple sclerosis. So what are these? The first one is called as Lhermitte sign. We write it with an L, but L is silent, so we don't pronounce it as Lhermitte sign. It is usually pronounced as Lhermitte sign. The second one is called as Pulfrich phenomenon. Pulfrich phenomenon, and the last one is called as Uhthoff's phenomenon. These names your teachers are specifically looking for, so if you write it, then they will be pleased to give you more marks. So what is this Lhermitte sign? This particularly applies to the spinal cord sensory tract demyelination. So if I cause spinal cord sensory tract demyelination, I will have some loss of sensations. And for such a patient, if you suddenly flex the neck, the demyelinated spinal cord gets stretched, and stretching irritates the remaining neurons, and it creates a shock-like sensation running down the spine. So that we call it as Lhermitte sign. What is it? It is a shock-like sensation on sudden flexion of neck. On sudden neck flexion. Okay. Then what is this Pulfrich phenomenon? This particularly applies to someone who has lost or impaired vision in one eye because of the optic nerve demyelination. I may become blind in one eye because of n number of conditions, right? Starting from the corneal diseases to lens diseases to the vitreous diseases to retinal diseases. Anywhere, anything, including optic nerve diseases, can cause blindness, right? But there is something peculiar about the loss of vision caused by optic nerve demyelination, right? Imagine that you're looking at one thing from two of your eyes. You're looking at this candle from two eyes, and then your optic nerve is taking that signal to the brain. And in one case, let us say in this case, the left eye is demyelinated. So this is dysfunctional or demyelinated. Will it totally lose conduction of information to brain? No. Myelin is mainly required for faster conduction. So this eye is also sending the signal to brain, but because myelin is damaged, it is conducting the signal to brain slowly. On the other hand, the normal eye is conducting much faster. So the same candle or same movement of the fire of the candle is captured by both the retina, but from this retina it reaches the brain quickly, almost like real time, but here it reaches slowly. So the brain is getting the same image twice. Once first from the normal conducting or fast conducting optic nerve, and the same image comes to the brain again through slow conducting optic nerve little later. Our brain is not designed to process this kind of information. Like imagine I'm taking a class and you're in the classroom. One guy gets up. So my real eye picks that up and sends to my brain. I mean, the unaffected eye picks it up and sends to my brain almost real time. But the same movement is delivered to my brain again by the slow conducting eye. Now it won't happen like a person stood twice. It's one person, so he will stand only once, right? But my brain got two images, one when it really happened and once little more later. Brain can't process it. It's not designed to process it. So it goes into a loop of illusion, and it starts adding an extra dimension to everything that we start seeing. So all the two-dimensional events start appearing to us as three-dimensional because of this brain's confusion to process same event happening twice. And that phenomenon is what we call as Pulfrich phenomenon. So Pulfrich phenomenon refers to 2D events being pursued as 3D events. Being pursued as 3D events. It can be simply and easily unmasked in the clinic. So we take a pendulum and start moving it left, right. Okay, it's moving left, right. So in how many dimensions it is moving? Left and right, means only 2 dimensions. So to me, it is 2-dimensional movement. But for this patient with multiple sclerosis with demyelination of one optic nerve, it is 3-dimensional. So how it will appear to him? It is moving left and right for sure, but it also appear to him move to and fro. So it is like it's moving to and fro as well as left and right. So for him, it becomes a 3-dimensional movement. This phenomenon, we call it as Pulfrich phenomenon. Okay. Then third one is Uhthoff's phenomenon. So what is Uhthoff's phenomenon? Uhthoff's phenomenon refers to heat sensitivity of symptoms. Heat sensitivity of symptoms. So what do I mean by that? It refers to transient worsening of symptoms. Worsening of symptoms on exposure to heat. What do you mean by that? Let us say I have one eye vision loss. Now vision loss means not absolute darkness, right? You know that there are different grades of vision loss. So let us say earlier I had a perception of hand movements. Okay, that's the level of my vision loss. I can perceive the hand movements, but I can't see, read or anything. But I can perceive the hand movement, and of course I will have light perception. Now I took a hot water bath. I got exposed to heat. My body temperature increased after hot water bath. So the moment I finish hot water bath, I will lose this perception of hand movement also. So my blindness worsened. But it is transient. As my body starts cooling down, again the perception of hand movement will return. Another example I can give is, let us say I have right upper limb weakness. How weak I am? I have a power of 3 out of 5. Power there is grading, and I have 3 out of 5. Now I develop fever. My body temperature increased. My power becomes 0 out of 5. But it will remain 0 out of 5 as long as I have fever. You give me a paracetamol, body temperature settles down, my power becomes 3 out of 5 again from 0 out of 5. So transiently on exposure to heat, the symptoms worsen. This we call it as Uhthoff's phenomenon, right? So these three phenomena, if they are accompanying the other symptoms, they are highly suggestive of multiple sclerosis, still not diagnostic. So how will I diagnose multiple sclerosis? Of course, from symptoms we only reach the site that is getting affected. Whether that site is demyelinated or not, we have to investigate. So in terms of investigation, we are following two important investigation. If you ask me what is the investigation of choice, I can see demyelination on MRI. So MRI is the investigation of choice. Okay. So on MRI, demyelinating lesions appear as oval shaped hyperintensities. Where do I find them? Of course, depends on where is the demyelination. If cerebellum is getting demyelinated, I will see a oval shaped lesion in the cerebellum. If spinal cord is getting demyelinated, I will see a oval shaped lesion in the spinal cord. If it is subcortex, I'll see it in the subcortex. So it depends on where the demyelination is happening. But how does it appear? It appears as a oval shaped hyperintensities. If seen in periventricular region. So if these oval shaped hyperintensities are seen in periventricular region, we will call it as Dawson's fingers. Dawson's fingers. So what are these Dawson's fingers? These are nothing but areas of demyelination. So if this is the brain, and if you have this ventricle here, and on top of the ventricle you will have this corpus callosum, and here if you have these oval shaped demyelinating lesions in the periventricular region. So this is your ventricle. These oval shaped hyperintensities is what we call as Dawson's fingers. Why are they called as Dawson's fingers? Because they appear like finger-like projections coming out from the ventricle. It looks like someone sitting in the ventricle is poking their fingers out. That's why they are called as Dawson's fingers. This is also something which is very frequently encountered in patients, and your teachers want to see this in the answer sheet. So I want you to mention, and if possible, do a simple sketch of these Dawson's fingers. Okay, so that is one investigation. The other investigation that we can do apart from this MRI can directly show you where is the demyelination happening. The other investigation that we can do is going to be CSF analysis, because there is antibody mediated and cell mediated injury to the myelin of the neurons of the CNS. Antibodies will reach the central nervous system through CSF. So CSF should have increased antibodies. Antibodies are chemically what? Proteins, immunoglobulins. So CSF protein will be increased. So there will be increased CSF protein. Particularly, I want you to remember, in the CSF protein, IgG will be increased. Why? Because these antibodies that we are speaking about, these are IgG antibodies, which are responsible for causing the demyelination. And what is the most common antibody? It is anti-myelin basic protein, or anti-MBP antibody. And this is IgG antibody. So in the CSF, IgG will increase. Normally, CSF does not have IgG. CSF has IgM, some amount of albumin and other proteins, but there is no IgG in CSF per se. But once you develop multiple sclerosis, IgG starts appearing in the CSF. So now I have to prove that this patient's CSF's increased protein is because of accumulation of IgG. So how will I be able to prove? Okay, so Tapa, when you want to see demyelination, CT is not a good investigation. You can't identify the demyelination easily on CT. So for demyelination, MRI is the best investigation. In fact, for most cases of CNS imaging, MRI is better investigation than CT, except when you want to screen for bleeding. CT is a very good investigation for the intracranial bleed. So if you're suspecting bleed, CT is the choice. Or to differentiate between bleed and infarct, CT can be a good investigation. But if you want to recognize the tumor, basal exudates, demyelination, best is MRI. Okay. So whenever we want to see that there is a mixture of proteins and we want to identify what all proteins are there in that mixture, what is the best investigation? Electrophoresis. So we can also do CSF electrophoresis. And CSF electrophoresis, you know how electrophoresis of the proteins works. Based on the molecular weight and charge, the proteins are smeared as bands. So the normal CSF does not have IgG. So there will be no IgG band. Like if I distribute the proteins according to the molecular weight, so there may be a band appearing for IgG, for IgM, okay, then for albumin. It's like band-wise distribution. But if I do it for CSF, there will be no band for the location of IgG normally. But once there is development of multiple sclerosis, in the place where there is no band for IgG, now a band appears because IgG is present in the CSF now. So this band we call it as oligoclonal band. So CSF electrophoresis shows presence of oligoclonal bands due to IgG. Normally there is, if you want, you can make a note. Normally no IgG in CSF. Very, very important point for the MCQ based exam. So any MCQ based exam, if it is talking about patient having some neurological symptoms and the presence of Dawson's fingers or presence of OCBs or oligoclonal bands, it is talking about multiple sclerosis. Okay, so these are the two important investigation. Then there is something called as a criteria for diagnosis. The criteria is called as McDonald's criteria. Okay, so what this McDonald's criteria says is a definitive multiple sclerosis is diagnosed if patient meets two criteria. There should be more than or equal to 2 events of demyelination disseminated in time. So we just learned that multiple sclerosis is a disease where there is recurrent attacks of demyelination. It's not like one attack, just like alopecia areata, right? Keeps happening again and again. So I need to call it as multiple sclerosis. I need evidence of at least 2 events of demyelination which have happened at 2 separate time frame, not simultaneously. Like, okay, today I have demyelination of cerebellum and spinal cord simultaneously happening. That is one event. That's not 2. I need 2 events. So maybe today I have demyelination of cerebellum. 6 months later, I develop demyelination of sensory tract in the spinal cord. These are 2 events, right? Separated in time. Disseminated in time means separated in time. By how much? By more than or equal to 1 month. So at least 1 month apart, there should be 2 events of demyelination. Plus, you also need evidence of more than or equal to 2 events of demyelination disseminated in space. What do you mean by disseminated in space? It refers to anatomy. Space means the anatomy, 3-dimensional anatomy of the central nervous system. Like if I have demyelination of cerebellum today, I recover from it, and then 6 months later again I have the demyelination of the same site in the cerebellum. So 2 events which are disseminated in time, yes, done. They are more than 1 month apart, but they are affecting the same anatomical structure. Then I can't call it as multiple sclerosis. But if I have demyelination of cerebellum today and 2 months later I have demyelination of spinal cord, they're separated by more than 1 month, so dissemination in time is there. And dissemination in space is also there because now they are affecting 2 different spaces or anatomical structures. One cerebellum, the other time spinal cord. Then you can call it as definite multiple sclerosis. And this is the essence of McDonald's criteria. You need 2 events of demyelination which are separated by 1 month apart and they are affecting 2 different anatomical structures. So once I have diagnosed it as multiple sclerosis, before we go to the management, Epstein-Barr virus is a risk factor not just for multiple sclerosis but various other autoimmune disorders. So you can write it for like type 1 diabetes mellitus, you can write it for the vitiligo, you can write it for so many of autoimmune disorders. Like you can close your eyes and write vitamin D deficiency and Epstein-Barr virus infection as risk factors for autoimmune disorders. Okay, now coming to the multiple sclerosis, we learned about its diagnosis. 2 investigations, MRI, Dawson's fingers, CSF oligoclonal bands. Criteria is Escorial, the McDonald's criteria. 2 events of demyelination separated by more than 1 month affecting 2 separate anatomical structures is how we diagnose a definitive multiple sclerosis. Now before we talk about management, let us understand how a patient of multiple sclerosis behaves over time. The classification of MS is based on disease behavior. Okay, for the reference, let us take the example of alopecia areata. Okay. So I have few known friends of alopecia areata where they get a patchy loss of hair. Okay. Now when they get that patchy loss of hair, so I have a friend who gets that patchy loss of hair once in a 2-3 years, there for 3-4 months, and then he starts seeing the growth of hair. Sometimes he takes a topical steroid cream or an injection into that lesion and it accelerates the regrowth. But every time he loses hair, he's pretty damn confident that it will come after 4-5 months, leave it, man. It's not a big deal. But I also have another friend who had a reasonable area of scalp patchy hair loss, and he is struggling to recover the hair. And every new patch appears, the hair doesn't come. Both of them are cases of alopecia areata. But for the first one, the disease is behaving very mildly, right? Every time he loses some patch of hair, it comes back. But for the second patient, every time a new patch appears, that area is gone. So he is accumulating patches on the scalp. So now he's having pretty large areas of the scalp hair lost. He's also started noticing patches on the body and nothing is recovering. Both are alopecia areata, but one case it is behaving aggressively, other case it is behaving less aggressive, right? So multiple sclerosis is also very similar. For many patients, recurrent attacks of demyelination happens, and every time demyelination happens, after a few months, it gets remyelinated and they are fully back to normal. Like, let us say cerebellum demyelinated, now I have ataxia, action tremor and all of that. But slowly cerebellum gets remyelinated, so after 3-4 months, I no longer have ataxia, I no longer have dysdochokinesia, I no longer have action tremor. But after 6 months, I will have demyelination of, let us say, cranial nerves. Now because of that, I may have facial palsy or any of the cranial nerve deficits. But after a few months, remyelination happens and I recover. That is one patient. Multiple attacks of demyelination, but every time complete remyelination, complete recovery. But I have another patient who gets recurrent attacks of demyelination, but every time there is demyelination, there is no recovery. That area of the brain is gone and that function is lost. So let us say first time he had cerebellum demyelination, no remyelination occurred. So he will have ataxia for rest of his life. But after 6 months, he had demyelination of optic nerve. Now he lost vision of the eye also. So now he is ataxic as well as vision loss. After 1 year, let us say he developed demyelination of sensory tracts in the spinal cord. So now he can't feel the sensation. So he is now ataxic. He has lost vision. He can't feel the sensation. So what is the story of this person? This person becomes progressively disabled. He keeps losing his abilities, ability to see, ability to feel sensations, ability to move body parts, progressively becoming disabled. The first patient, he becomes disabled only for that period where there was demyelination. Once there is remyelination, he is no longer disabled. So based on this disease behavior, we have 3 major types of multiple sclerosis. You are expected to put these graphs in the exam because your teachers are pretty much likely to expect you to write these graphs. So we will have the disease behavior plotted on the graph. And in this first graph, it kind of looks like this. So can anybody tell me what am I plotting on this graph? Of course, on the x-axis, I am plotting time from the diagnosis over several months to years, how the disease is behaving. But what am I plotting on the y-axis? So on the y-axis, we are plotting the disability. And for this plotting of disability, we are following Kurtz's scale. It's called as Kurtz's expanded disability severity scale, or Kurtz's EDSS. So we will, what Kurtzky has done is he has listed human abilities, like basically telling you what are the abilities: to see, to smell, to taste, to move limbs, to feel pain, to feel temperature. So there is a list of abilities. And whenever demyelination happens, I lose some of these abilities depending on which part is demyelinated. So what happened? My disability increases. Whenever there is demyelination, disability increases. So first patient's behavior is he had demyelination, disability increased. As long as the myelin was not there, disability remained like that. But after some time, remyelination started happening, so disability started decreasing. So from the graph, we can understand that every time there was demyelination, patient eventually recovered. So his disability came back to baseline. So he was disabled only for small periods during the phases of demyelination, but after that he had recovered completely. So every attack of demyelination results in complete recovery eventually. So these patients, we will call it as relapsing and remitting type of multiple sclerosis. We are calling it as relapsing and remitting type of multiple sclerosis, usually abbreviated as RRMS, relapsing remitting multiple sclerosis. Why are we calling it as relapsing and remitting? Relapse means disease coming back again. Remission means recovery. So every time it comes, we recover. It's just like my first friend of alopecia areata. He gets a new patch. 3 months later, hair is back. He will get a patch of alopecia areata again after a few months, but then 3 months later, the hair is back. So his scalp after the disease recovery looks fully normal, right? So what is the prognosis of this patient? I will count it as quite good. Because yes, multiple sclerosis means recurrent attacks of demyelination will happen, but every demyelination is met with good recovery. So such patients have good prognosis. Good prognosis, and they are the most common type. They account for more than 85% of cases. So good that majority of the multiple sclerosis patients will have recurrent attacks, but they will make complete recovery from each attack. But I can't say the same for the next patient. The next patient's graph kind of looks like this. So if I plot time on x-axis and disability on y-axis, what does it look like? The disability just kept on increasing. It never came back to baseline. For the first case, after every demyelination, disability increased, but it came back to the baseline after every recovery phase. But here, no recovery ever happened. So let us say first time he had optic nerve demyelination. So he can't see now. Because of that, his disability increased. Now it has reached this point. Now, after this, let us say he had demyelination of the spinal cord, mainly sensory tract. So now he can't see, did not recover the vision because optic nerve remained demyelinated. Now the spinal cord also demyelinated, he can't feel the sensation. So his disability reached this level. After this, let us say he had demyelination of cerebellum. So now he can't see, he can't feel the sensations, and now he has ataxia. So his disability further increased. It reached here. Now here, let us say he had demyelination of brainstem, and because of that, his cranial nerves are dysfunctional. So now he can't see, can't feel the sensations, has ataxia, and he has lost cranial nerve functions also. So his disability further increased. He will have one more demyelination. Let us say this time pyramidal tract got demyelinated. Now he has motor weakness also. His disability will further increase. So with time, there's no recovery. Disability just keeps on accumulating, and he will reach the peak of disability somewhere. So this patient is rapidly progressing towards death because he keeps losing his abilities or bodily functions. So this kind of multiple sclerosis, we will call it as primary progressive. We will call it as primary progressive. Why are we calling it as primary progressive? Because right from the first event of demyelination, there is no recovery at all. It is just progressing. He keeps adding new areas of demyelination, new disabilities. And this is the second most common type, and of course it carries poor prognosis. It carries poor prognosis. Then the third graph kind of looks like this. This is the third graph. So the third graph kind of looks like the combination of the first. The first half of the graph is like the relapsing and remitting type. Second half of the graph is like primary progressive. So what is the meaning of this graph? So initially, every time there was demyelination, patient was making complete recovery. The disability was coming back to the baseline. Again, a demyelination, it was increasing, but he was making a complete recovery, so it was coming back to baseline. But after some time, the recovery stopped. Now the demyelination is not remyelinating. So he starts accumulating disability. So first it behaved like relapsing and remitting. Now it is behaving like primary progressive. So this kind of disease behavior is called as secondary progressive. This is called as secondary progressive multiple sclerosis. This is rare, less common. This is rare or less common, and we will count this as having moderate prognosis because see, relapsing and remitting has the best prognosis because every time demyelination, remyelination and full recovery. This has poor prognosis because every time demyelination, no recovery, progression of disability. Here, at least initially he was recovering. Eventually recovery stopped, but at least initially he was recovering. So I will keep its prognosis somewhere between the two, right? So we'll call it as moderate prognosis or modest prognosis. Not too good, not too bad. So these are the three disease behavior based types of multiple sclerosis. Why is that important, you may ask me? The importance is with respect to management. We're calling it a secondary progressive because the progression started later. Here, from the first event of demyelination itself, there was no recovery. So the disability kept adding. So it kept progressing from the beginning. Here, initially we were recovering later. So this part, if I had seen the patient here before the disability accumulation started, I would have actually called it as relapsing and remitting multiple sclerosis. Only when the recovery stopped happening, then I will call it as a progressive variant. But because initially it was behaving like relapsing and remitting, we will call it as secondary progressive. In this case, from the first event itself, it was behaving like a progressive disease. That's the main difference. Okay. So now coming to the management. If you have a case of multiple sclerosis, there is two levels of management. There is an acute treatment and preventive treatment. Why is this required? Reason is simple. We are dealing with a recurrent disease, right? Multiple episodes of demyelination will happen if it is multiple sclerosis. That's why we are calling it as multiple. Okay. So now the question is, when I'm going through demyelination, let us say I'm going through cerebellar demyelination right now. So I have ataxia, I have dysdiadochokinesis, I have intention tremor, I have nystagmus, all of these I'm going through. Can you as a doctor do something to accelerate the remyelination and recovery from this cerebellar dysfunction? If you can do, I will call it as acute treatment. Acute treatment's goal is to accelerate the remyelination process by stopping the ongoing demyelination. But then as a doctor, you know that today the cerebellum is recovered, but then I will again come back to you with another area getting demyelinated, because it's multiple sclerosis means it will keep recurring. So can you do something to prevent that future demyelination episodes from happening? Well, if you can do something, that is your preventive treatment. So what do we do for acute treatment when there is an ongoing event of demyelination? Mainly we do high dose methylprednisolone. Suppress the immune system so that it does not cause the damage to myelin. Once you stop the damage, only then the remyelination starts, right? So when we say high dose methylprednisolone, how much we are talking about? 500 milligrams to 1000 milligrams, that is 1 gram, 1000 milligrams per day IV for 3 to 5 days. This is pretty high dose of steroids. So like let us say I diagnose a multiple sclerosis, the patient is now going through optic nerve demyelination. Now for 3 to 5 days I will give him high dose steroids. That will stop the, hopefully stop the ongoing demyelination. Once the demyelination stops, the process of remyelination starts and slowly he will have recovery of the vision. That is the objective. But now to prevent another episode of demyelination affecting some other body part, some other nervous system structure, we will have to give preventive treatment. And this is where the role of disease behavior comes into picture. Because for preventive treatment, the drugs used depends on whether it is primary progressive, secondary progressive, or relapsing and remitting. So if it is relapsing and remitting multiple sclerosis or the secondary progressive multiple sclerosis, then we can use drugs like, there's a long list. I will list only the important ones that you need to remember. One of them is fingolimod, siponimod, dimethyl fumarate, because Sutapa Samantha, the multiple sclerosis has a cell mediated as well as antibody mediated immune damage to the neurons, the myelin sheath. The cell mediated immunity has to be absolutely suppressed to minimize the cell mediated injury to the neurons, and that is only possible when we give high dose steroids so that we can achieve sufficient concentrations of the steroids in the central nervous system. Okay, so these are oral drugs. Apart from that, we have modern biologicals like natalizumab or rituximab and ocrelizumab. The list is very long in your pharmac books. At least these are what your teachers are expecting to write. And when you're writing about monoclonal antibodies, you are expected to write their target antigen as well. So it is alpha-4 integrin. Alpha-4 integrin blocker is your natalizumab. CD20 blocker is rituximab. Similarly, CD20 blocker is ocrelizumab. So these are all monoclonal antibodies that can be used for relapsing and remitting and secondary progressive. But for the primary progressive multiple sclerosis, currently we have limited approved drugs. The only one thing that is available right now in India is ocrelizumab, which is again anti-TNF CD20. Remember, CD20 is a marker of B lymphocytes. B lymphocytes are the ones which are producing antibodies. So if I suppress B lymphocytes, antibody production will come down. So future episodes of demyelination will also come down. This is particularly important, especially for a Viva, OSCE, or your bedside discussion. If you land up with a multiple sclerosis case, which is quite unlikely, most of your major cases for neuro will be stroke or peripheral neuropathies, diabetic neuropathy. But if you get multiple sclerosis, discussion may go to a point where your teachers might ask, tell me one drug which I can use regardless of which disease behavior pattern the multiple sclerosis is showing, whether it is showing secondary progressive, primary progressive, or relapsing and remitting. And your answer is going to be ocrelizumab, because it can be used for secondary progressive, primary progressive, as well as relapsing and remitting. So it can be used for all types of multiple sclerosis. But the other drugs that we listed are currently only approved for relapsing and remitting or secondary progressive multiple sclerosis, right? So that completes our discussion on multiple sclerosis as well. Now we will have a small note on another important demyelinating disorder of the CNS. And that demyelinating disorder of the CNS is neuromyelitis optica. Neuromyelitis optica. So what is this neuromyelitis optica? It is also a demyelinating disorder of the central nervous system, pretty same as multiple sclerosis with subtle differences. So multiple sclerosis was an autoimmune disorder. Neuromyelitis optica is also an autoimmune disorder. It's a demyelinating disorder of CNS. Now multiple sclerosis was due to which antibody? Anti-myelin basic protein antibody. That's the most common antibody. Apart from that, you had cell-mediated injury also. So here it is due to anti-aquaporin 4 antibodies. Anti-aquaporin 4 antibodies. So aquaporins are water pores or channels, and they are present in the CNS also. So they can get targeted, and that can result in damage to the myelin sheath. So here the patients present with the common presentation of neuromyelitis optica. It is there in the name. Here, multiple episodes of demyelination, just like multiple sclerosis. The most commonly affected structure is going to be spinal cord here also. And the second most commonly affected structure is going to be optic nerve here also. Then what is the difference? How will I differentiate without investigation? Is it possible for me to clinically identify whether it is neuromyelitis optica or multiple sclerosis? Yes, possible. How is that possible? Well, the first thing is, when spinal cord gets affected, it involves more than 3 spinal segments. In MS, the demyelination of spinal cord generally stretches to less than 3 spinal segments. Now, what do I mean by segments? You know that spinal cord, right? According to the adjoining vertebral bones, we have classified it into cervical segment, thoracic segment, lumbar segment, sacral segment, right? So let us say there is a patient whose spinal cord shows a hyperintensity or a lesion, which is spanning from C1 segment all the way to C6, means C1, C2, C3, C4, C6, whole one big line of demyelination is visible. C1 to C6, one big line of demyelination is visible. How many segments it is spanning? 6 segments it is spanning. Can it be multiple sclerosis? Unlikely. Multiple sclerosis, demyelination generally stretches to less than 3 spinal segments. Like C1 to C2, there is demyelination visible. Only 2 segments, C1 and C2. Likely multiple sclerosis. But if it is 3 plus, it's likely neuromyelitis optica, right? The second clue is, when demyelination of the optic nerve happens, in multiple sclerosis, it is unilateral. But in case of the neuromyelitis optica, it is going to be bilateral. It's going to be bilateral. Okay, these are the 2 points you need to write. And then in terms of prognosis, it carries poor prognosis than multiple sclerosis. Why? Because neuromyelitis optica behaves like the primary progressive variant of multiple sclerosis. Means every time there is an attack of demyelination, generally there is no good recovery. So they keep adding disability more faster. But majority of multiple sclerosis behave like relapsing and remitting. Means 85% cases, every time demyelination they recover. Neuromyelitis optica, every time demyelination they don't recover. That's why it carries poor prognosis, right? So these are the extra points you need to write under neuromyelitis optica. So that completes our discussion on the demyelinating disorders of the central nervous system. Now we'll take one more important question, that is on stroke. That is on stroke. So what is stroke? Can anybody define what is stroke? So stroke is defined as a okay, have we covered the stroke in the previous neuro? Just let me check. Okay, we have not covered, so I will address the stroke now. So what is stroke? Basically, stroke refers to, see, hemiplegia is not equal to stroke. This is a common mistake that students do while giving the case presentation. Bedside discussion, the teachers ask what is stroke. Even before giving a verbal answer, you start giving the signal, one side of the body, right? Physically, you start giving the clue. Teachers get quite pissed off or irritated at that answer. Because hemiplegia can happen anywhere, like anytime there is a damage to the brain or the brainstem. If you do a unilateral damage to brain or brainstem, you may end up with hemiplegia. That damage could be because of infection, tumor, a bullet lodging in the pyramidal tract, or like an abscess, or bleed, or infarct, anything. So hemiplegia is only a manifestation of a particular part of the nervous system being affected. That's not always equal to stroke. So then what is stroke? Stroke is defined as focal. What do you mean by focal? Some part of the brain. Or global. Global means all of the brain. Focal or global neurological dysfunction. So brains, some part or all of the brain is becoming dysfunctional. It can become dysfunctional because of infection, because of bleed, abscess, infarct, like n number of causes. But if it is due to a cause in the blood vessel, due to vascular origin, then we will call it as stroke. So the problem has to be because of a blood vessel. Then we will call it as stroke. And what can go wrong with the blood vessel? Either you can develop bleed. If you develop bleed, you will call it as hemorrhagic stroke. Blood vessel can have two problems. Either it gets blocked by a clot or an atheromatous plaque, or it ruptures and bleeds. If it ruptures and bleeds and because of that some part of the brain or whole of the brain loses the function, it is hemorrhagic stroke. But if it gets blocked by an atheromatous plaque or the blood clot, and then we will call it as ischemic stroke. So we will have two types of stroke, hemorrhagic stroke and ischemic stroke. So now let us learn the classification. In the definition we have to add one more point. These neurological dysfunctions should last for more than or equal to 24 hours or until death. But if recovery of the neurological dysfunction happens within 24 hours, we can't call it as stroke. So what should I call it as? We will call it as transient ischemic attack. So neurodeficits that resolve, completely, means I had hemiplegia, but after 2 hours it's no longer there. Completely within 24 hours without an objective evidence of an infarct, then we will call it as transient ischemic attacks. The main difference between the stroke and TIA is, in stroke the deficit lasts for 24 hours or higher. After that slowly there may be recovery. A lot of stroke patients make complete recovery. But if recovery happens within 24 hours and when you scan the brain you don't find any infarct, then we will call it as transient ischemic attack. And if TIA has happened today, that means you had risk factors for stroke, but lucky enough that recovery happened quickly. But in the near future you may get a full-blown stroke and you may not recover from that. So TIA is a strong risk factor for stroke. Okay, that's something that I want you to remember. Now let us understand the classification of stroke. So classification of stroke is based on whether it is ischemic or hemorrhagic. So we'll classify the stroke into two groups, the ischemic stroke and hemorrhagic stroke. So many authors also consider the occlusion of the brain veins, cortical vein thrombosis, as stroke. Many traditional authors do not count that as stroke. So I will leave it to you. If your teachers often talk about cortical vein thrombosis also under the stroke, then write a few lines about cortical vein thrombosis also in your stroke concept. If your teachers don't specifically talk about it, then restrict to ischemic and hemorrhagic stroke. Now, when we talk about ischemic stroke, we understand that some part of the blood vessel got blocked. Because of that, the area supplied by that blood vessel is not getting the blood supply, and the neurons there are dying, resulting in infarction. But why the blood vessel gets blocked? There are two possible mechanisms. One, a clot can get formed somewhere, travel through the blood vessels and come and block this particular brain's blood vessel. In that case, such stroke, we'll call it as thromboembolic stroke. We will call it as thromboembolic stroke. A clot formed elsewhere travels to the brain's blood vessels and block it. What is the most common cause? The most common cause for a thromboembolic stroke is atrial fibrillation. Why atrial fibrillation becomes a cause for the thromboembolic stroke? The reason is simple. So in atrial fibrillation, there is inadequate contraction of the atria. And because of that, there is a high probability that there may be formation of a clot in the left atrium. Why? Because we know that there is something called as Virchow's triad. Virchow had given the risk factors for formation of a spontaneous clot. So what are those risk factors? One of them was stasis. Second one was hypercoagulability. The third one was endothelial injury. So when these are there, there is a chance of developing a clot, and this triad was called as Virchow's triad. So atrial fibrillation provides one of the component of this Virchow's triad. What is that component? Stasis. Because atria in atrial fibrillation doesn't contract, just starts shaking or fibrillating. So if it is not contracting, it is not squeezing, so the blood remains stagnant in some parts, and because it is stagnant, it will develop a clot. But once a clot forms in the left atrium, it can make its way to the left ventricle, from the left ventricle to aorta. From the aorta, the anatomical organization of blood vessels is so that most likely the clot coming to the aorta goes to the carotids rather than traveling the arch and going to the lower limbs. And from the carotid to internal carotid to most likely it goes to middle cerebral artery. And as the middle cerebral artery's diameter narrows down, somewhere it gets stuck. So rest of the middle cerebral artery does not get any blood flow now because this clot has blocked it. And that's why whenever you study about atrial fibrillation, you study about the role of anticoagulation, because there is increased risk of stroke, right? So atrial fibrillation is the most common cause for thromboembolic stroke. Then many times what happens is a clot is not coming to the blood vessels from somewhere else. A clot develops within that blood vessel, right? In that case, we will call it as thrombotic stroke. Thrombotic stroke. In many books, the thromboembolic stroke is also called as cardioembolic stroke, because the most common site where a clot gets formed is left atrium for the clot to come to the brain. Other locations also clot may get formed, like a carotid artery, it may get formed, then it get dislodged from the carotid and go to the brain. But most commonly it is the heart. That's why it's also called as cardioembolic stroke. Okay, now the thrombotic stroke. Let me explain why the thrombotic stroke happens. So the in atrial fibrillation, atria does not contract, and if does not contract, the blood stays there unmoved, static, stasis of blood, and stasis is a risk factor for development of clot. And if a clot gets formed in the left side of the heart, it will go to aorta. From aorta, it will go to the middle cerebral artery. The thrombotic stroke most commonly happens. There are a lot of risk factors for thrombotic stroke. We will write it down in a minute. But the whole problem starts with, we just now learned about the Virchow's triad, and Virchow had said that there is risk of developing a clot if there is endothelial injury. Okay, so basically what happens is, we have this atheroma or cholesterol accumulation in the blood vessels as the aging process starts, and if you smoke, if you have an unhealthy lifestyle, it accumulates much rapidly. So we call it as an atheromatous plaque. As the plaque expands, one day the plaque might rupture, and when the plaque ruptures, the plaque rupture often results in the injury to the endothelium. Because how will it rupture? It will rupture by passing through the endothelium. And once there is endothelial injury, we activate the platelet plug formation, eventually fibrin mesh formation, and we create a clot and occlude this blood vessel completely. So that's why accumulation of this cholesterol is a risk factor, because somewhere down the line in future, this atheromatous plaque may rupture, invite platelets and fibrin to form a clot, and then it's gone, right? So in thrombotic stroke, a clot gets formed within the brain's blood vessel, the reason being atheromatous plaque formation or other causes for endothelial injury. So here we can't pinpoint one exact cause, but rather we can list important risk factors. So what are the important risk factors for the thrombotic stroke? Okay, so first let me list the important ones that you should not miss. So one of them is dyslipidemia, especially which parameter in the lipid is important risk factor? Elevated LDL cholesterol, right? High LDLC is a risk factor. Hypertension is a risk factor. Hypertension, in fact, is the most common risk factor for thrombotic stroke. Okay, diabetes, whether type 1 or type 2. In fact, diabetes is the strongest risk factor, because diabetes increases the rate of deposition of the cholesterol. More and more cholesterol gets deposited in your arteries because of diabetes. So the risk of that cholesterol plaque rupturing somewhere in the future and causing the clot and thus occluding the blood vessel increases. So diabetes is the strongest risk factor. Hypertension is the most common risk factor. Apart from that, increased homocysteine levels is recognized as a hyperhomocystinemia is recognized as a risk factor. Other than that, if you see patients of stroke in your hospital, you will notice that most of them are aged. So age more than 50 years is a risk factor. Most of them are males. So male gender is a risk factor. Family history is a risk factor. Obesity is a risk factor, and so is smoking. So these are all risk factors. Sometimes the questions from some of the universities might ask you to elaborate on modifiable and non-modifiable risk factors. I'm not going to elaborate here. I will leave it to you. You can write it logically. How many of these are modifiable and how many of these are non-modifiable? Dyslipidemia, is it a modifiable risk factor or a non-modifiable risk factor? It's of course modifiable, right? Because I can have dietary restrictions. I can give you statins, fibrates. So there are drugs to lower the cholesterol. So it's a modifiable risk factor. Hypertension, yes, it's a modifiable risk factor. I may not be able to cure, but I can control the blood pressure. Diabetes, I may not be able to cure, but I can control the blood sugar. So these are all modifiable. Hyperhomocystinemia, again a modifiable risk factor. But age, it's non-modifiable. Gender, non-modifiable. Family history, non-modifiable. What about obesity? Modifiable, right? You have the choice of cutting down the calories, working out, and bringing your weight down. Smoking, you have the choice of quitting. So there are modifiable and non-modifiable. If your university paper asks you to elaborate on it, you can write it logically, right? So this is about ischemic stroke, thrombotic and thromboembolic. Thrombotic is a clot formed within the blood vessel. Thromboembolic, clot formed elsewhere, comes to the brain's blood vessel. Then we have hemorrhagic stroke. Under hemorrhagic stroke, we have two. Under hemorrhagic stroke, we have intraparenchymal bleed and subarachnoid hemorrhage. So you have, I want you to note that the subdural hematoma and epidural hematoma, right? These are not considered as stroke. So can anybody tell me why these are not stroke? But subarachnoid is stroke, intraparenchymal means bleed in the brain's tissue is stroke, but bleed happens in the epidural space or subdural space is not stroke. If it is in subarachnoid space, it is stroke. Inside the brain's tissue, it is stroke. Because it all boils down to the definition of stroke. What stroke is defined as focal or global neurological dysfunction because of a problem in the blood vessel. So why bleeding happens inside the brain? The most common cause for intraparenchymal bleed is hypertension, and hypertension is a disease of the blood vessel. So a blood vessel's problem has resulted in loss of function of the brain. So I will count it as stroke. Subarachnoid hemorrhage, the most common cause is rupture of Berry aneurysms, and aneurysms are diseases of the blood vessel. So this also I can count it as stroke. But the subdural and epidural are usually because of trauma. Nothing wrong with the blood vessel. Blood vessel get torn because of trauma. There is no disease of the blood vessel. That's why they are not considered as stroke. These are basically traumatic brain injury, traumatic injury. There's nothing to do with stroke per se, right? So only two things come under hemorrhagic stroke: subarachnoid hemorrhage and interparenchymal bleed. Now in this question, they have asked us to elaborate the management and diagnosis of ischemic stroke. Okay, so let us discuss more about the ischemic stroke. But before that, let us understand the approach to stroke. Because many of your university papers begin with a case, and then they will ask you how do you evaluate further and how do you manage it. So we have to know how do we approach. So if I have a case of stroke, if I have a case of suspected stroke, and I want to manage it further, don't you think the management of ischemic and hemorrhagic stroke is poles apart? See, if there is an ischemic stroke, let us say this is the part of the brain that we are looking at, and one of the blood vessel which was supposed to give blood supply to this part of the brain is blocked, and because of this, all the area supplied by this blood vessel that is losing the function. The best way to treat it is remove this clot somehow, either by dissolving the clot or putting a wire and pulling it out. Remove the clot so that you can re-establish the blood flow and this area which is about to die can be recovered. So what is the easiest approach? Dissolve this clot through thrombolysis. But what if actually this patient had stroke because of bleed here and I do thrombolysis? The bleed will worsen, right? It will literally kill the patient. So I can't have the same management for ischemic and hemorrhagic. They are literally poles apart. So the first thing that I need to differentiate whenever I get a patient of stroke is to know whether it is ischemic or hemorrhagic. So how can I know whether it is ischemic or hemorrhagic? What investigation I should do? Of course, I have to do an imaging. I will tell you some points and you should decide whether you would like to go with CT or MRI. Okay. So CT scan can detect an infarction usually 6 hours or later after the onset of stroke. Sometimes early because of a blocked blood vessel being visible, but it's quite rare. Otherwise, most cases, an infarct is evident on the CT scan after 6 hours. An MRI can detect an infarction within 30 minutes or 45 minutes of onset. So what would you like to do? CT or MRI? CT or MRI? What would you choose? Well, it's not MRI. It's CT. So there is something very, very important for all of you to learn to become a good clinician in the future, right? Take it as a senior's advice. Whenever you write an investigation, before you write an investigation, you should have a question in mind. Your investigation is only to seek answers. It's not for documentation. It's not for patient satisfaction. It's not for your satisfaction. It's not for the cuts that the labs keep. It's always to find answer to a question. So you should have a question in mind before you write on an investigation. So here I have a question. What is it? I am having a suspected case of stroke and I want to know whether it is ischemic or hemorrhagic. So my question is ischemic versus hemorrhagic. My question is, or my urge is not to see an infarct. My urge is not to see a bleed. I have a clear-cut question. I just want an answer for this, whether it is ischemic or hemorrhagic. So any investigation that gives me this answer quickly will be my investigation of choice. Even if that investigation does not show me infarct, doesn't matter. I just want to get this answer. And for that, CT scan is more than enough. Why? CT scan is highly sensitive for bleed. It doesn't miss the bleed easily. So if I have a suspected case of stroke and I get a CT done, if it shows bleed, it is hemorrhagic stroke. If it does not show bleed, then hemorrhagic stroke is ruled out. So by default, it becomes ischemic stroke. The same patient, if I do a CT after 6 hours, it will show infarct, but I don't want to see it. I got my answer, right? So that's why whenever we have a suspected case of stroke, we will go ahead with the non-contrast CT. This is the investigation of choice. So the non-contrast CT, if it shows bleed, then it is hemorrhagic stroke. If it is hemorrhagic stroke, I will do initial stabilization and hand over the case to the neurosurgeon, because hemorrhagic stroke is, if required, they might have to do a craniotomy or a burr hole surgery to decompress, but it's not a medicine field. But if it is ischemic stroke, it's usually managed by medicine or neuromedicine. So if there is no bleed, then we are counting it as ischemic stroke. I don't have to see the infarct to call it as ischemic stroke. So the point I'm telling you is, whenever we ask for an investigation, it's not about seeing the findings. It's always about getting the answer to the questions that will help us manage the case further. So I have only one question. If it is ischemic, I know how to manage. If it is hemorrhagic, I know how to manage. I just want an investigation that solves this doubt whether it is ischemic or hemorrhagic. CT more than does that. So okay, let me give you an example. See, you have some suspected foreigner identified in India. You are believing that he is spying against our country and he is caught in India. Okay, now you have a question in mind: is he Indian or a foreigner? Right? There will be n number of ways to identify who is he, but I have only one question: is he Indian or foreigner? If he is Indian, I'm just leaving him here, right? I don't have anything to do with him. He will live his life happily. But if he is not Indian, I have to capture him and maybe deport or punish him legally. So if there is one investigation that clarifies my doubt, I will go with that. And the quickest and easiest way is, if this fellow has an Indian passport, authentic one, my doubt is solved. Or if I catch this fellow with, let us say, an American passport, then again my doubt is solved. So after that, see, if he is an Indian, whether he comes from Andhra, whether he is from Tamil Nadu, is none of my job. In India, he can roam freely wherever he wants. So I will not investigate further. My answer is sorted here itself. Or if I find out that no, he is an American, posing as Indian, then again I got my answer. Now I will take the next steps. I don't have to now figure out whether he's an American living in Andhra or whether he was an American living in Bangalore. No, I got my answer. Right? So same here. I don't have to see an infarct to treat the case further. Once I get a CT done, if it shows bleed, it is hemorrhagic. If there is no bleed, it is ischemic. Now I will start taking the next steps. I don't have to see the infarct, so I don't have to go for MRI. Okay, so if it is an ischemic stroke, I know that some blood vessel is blocked. But if I want to know, not always required, but if I want to know which blood vessel is blocked, what investigation I should do. So if needed, we can go for CT angiography. CT angiography to identify which blood vessel is blocked. Is it middle cerebral artery? Is it anterior cerebral artery? Is it basilar artery? Or is it internal carotid artery? We can do a CT angiography. It's not always required, but that's why I have written if needed. Okay, when is it needed? We will learn. So we now understood how do we diagnose stroke, right? If they're present, you should do a CT scan in the directly from the emergency room, take him to the CT room, get the CT scan done. If you find the bleed, it is hemorrhagic stroke, call the neurosurgeon, he will manage rest of the case. If there is no bleed, it is ischemic stroke, you have to take the next step, being part of medicine department. So what is the next step? Now you have a blocked blood vessel, because at that some part of the brain is not getting the blood supply. I want to open that blocked blood vessel so that I can re-establish the blood flow to the brain and hopefully recover the neurons. So how can I open that? That's what we'll try to understand. So we will learn the management of ischemic stroke. So first we will understand why I want to manage this case of stroke. So I want you to write first statement. Time is brain. This is a statement I want to appear in your answer sheet. Time is brain. What does that mean? Means after a blood vessel gets blocked, passing every minute means some part of the brain keeps losing its function, because neurons which are not getting the blood supply, they start dying. Okay, so we'll try to understand the objective. Just for the conceptual understanding, let us think that this is brain and we have this middle cerebral artery here in the Sylvian sulcus. This is our central sulcus, and just in front of the central sulcus, we have Brodmann area number 4, that is your motor area. So this area is concerned with regulating the body parts. Right motor area controls left upper and lower limb. Left motor area controls right upper and lower limb. Right. Just sitting next to this, you have this so-called Broca's area. Just giving this for a conceptual understanding. Broca's area. And in the temporal lobe somewhere here, you have this Wernicke's area. Just posterior part of the temporal lobe, you have Wernicke's area. This is Wernicke's area. Similarly, there are so many areas in the brain. Okay, all of them are going to get blood supply from different blood vessels. For this motor area, Broca's area, Wernicke's area, we are receiving the blood supply from the middle cerebral artery. So you can say that this is middle cerebral artery. And this middle cerebral artery has a superior division and has an inferior division. And the superior division is the one which is giving the blood supply to Broca's area and the motor area. Inferior division is giving the blood supply to the Wernicke's area. Okay. Now tell me, if I block this inferior division, what symptoms I'm going to expect? If there is a clot formed here or clot formed somewhere and came and blocked this, I will develop Wernicke's aphasia because this area loses the function. But will I have the paralysis of muscles? No. But what if I block the superior division? If superior division gets blocked, blood supply to Broca's area and motor area is lost. So now, because of motor area dysfunction, I will have contralateral hemiplegia. And because of Broca's area, if it is dominant lobe, that dysfunction will lead to Broca's aphasia. This patient will present with Broca's aphasia and hemiplegia. That is his presentation. So now as a doctor, I'm treating. Let us say there is a block here and I'm going to treat. If I open this block, the blood flow is re-established and these areas will start functioning again. So his Broca's aphasia and hemiplegia will disappear. He will be back to normal. Right? Is that always the outcome that we can get? No. Why? Because once I block this blood vessel, there is a limit how long these neurons can survive. Because once the blood supply is cut, they can survive for only a short period of time. After that, they die. Once they're dead, after that, opening the blood vessel makes no sense. I will not be able to recover the functions. Like if Broca's area is dead and after that I reopen the blood vessel, blood flows to the Broca's area, but the neurons are dead. So what's the point? If motor area is dead and then I open the blood vessel, blood flows to the motor area, but I can't recover the functions. So the main goal of stroke is to open the blood vessel well in time before the neurons are dead. That's why we say time is brain. The more time you spend before you can open the blood vessel, more neurons are dead. Right? You got that point? So timely intervention is important. How much time I have to open this blocked blood vessel to give some benefit to patient? So studies have shown that if you block a blood vessel in the brain, the neurons die completely in that all that area supplied by this particular blood vessel, all the neurons are dead by the end of 24 hours. So you have 24 hours of window where you can give some benefit to the patient. Like let us say I do intervention and remove this clot after 20 hours. So by that time I would have lost 80% of the neurons, but still 20% I can save. But if I open this blocked blood vessel within 30 minutes, maybe I save 95% of the neurons from dying. So the chances of complete recovery is more the earlier I open the blocked blood vessel. But after 24 hours, no benefit derived at all. So 24 hours is where you can do something for the patient. If he comes to you after 24 hours, nothing you can do. You can only prevent further episodes of stroke, but current episode of stroke cannot be recovered at all. Right? So that's why time is brain. So timely intervention is required. And what intervention we can do? The definitive treatment of stroke is going to be revascularization. Revascularization. What does that mean? Opening of a blocked blood vessel. And this revascularization can be achieved by two methods. One is thrombolysis. You can give medications to dissolve the formed clot. Second is called as mechanical thrombectomy. It is similar to angioplasty. So what you do is you take a catheter, pass it into the carotid. From the carotid, you make your way to the blocked blood vessel. here in this example, we have superior division of MCA block. So if I can pass a catheter, catch hold of this clot and retrieve it or remove it, there are specialized devices for that removal. Once I remove it, the blood flow is re-established. So this, like mechanically, I'm going there and removing the clot. That's why it is called as mechanical thrombectomy. But if I give medication to dissolve this clot, we will call it as thrombolysis. These two choices are there. Both of them have their own risks and benefits and own time frame under which we can do it. Okay, so first we will understand thrombolysis because that is more commonly practiced, available from many decades, and then we will talk a little bit about mechanical thrombectomy, right? Thrombolysis is what is commonly discussed by the universities because there are indications and contraindications. Okay, so first thrombolysis. So what are the indications? So it is indicated, see, remember the neurons are completely dead by 24 hours of blocking the blood vessels. So 24 hours is the window period, but I can't do thrombolysis up to 24 hours because the risk thrombolysis is by giving those medications which induce the plasmin in the body to produce more thrombolysis. And because of that, there is increased risk of bleeding. So we are always trying to weigh the risks and benefit. These are highly risky drugs. Patients may bleed to death. So when we are giving them, we should know that the benefits of this medication is overweighing the risk, and that can happen only up to 4.5 hours or max 6 hours. After 6 hours, the risk of bleeding is higher than the benefit because by 6 hours, we would have lost 70-80% of the neurons. Only 20-30 may be remaining. To salvage those remaining minimal neurons, we are taking a big risk. So we don't want to do that. So it is indicated in acute ischemic stroke patients presenting within 4.5 hours. Some of the books also mention 6 hours. If you mention 6 hours also, it is fair enough. Just be prepared to tell your teachers that sir, books mention 6 hours. The international neuro guidelines generally talk about 4.5 hours. Both of these are acceptable answers. So any ischemic stroke patient presenting within 4.5 hours of the onset of stroke, we can go for thrombolysis. After 4.5 hours, the risks outweigh the benefits. That's why we don't do it. This is the answer you have to give to your teachers. So why don't you do it? Because up to 24 hours, there will be some neurons still alive. So why don't you do it? So it's always about risk and benefit. Like if you have a small thorn in your leg, you don't ampute the leg because the risk of amputating a leg is far more than that injury caused by the thorn, right? So same here. So the minimal neurons that are surviving after 4.5 hours or 6 hours. So to help them recover, if I give a thrombolytic agent with a very high risk of bleeding, the risks outweigh the benefits. That's why we're doing up to 4.5 hours. So what are the contraindications? This is the basic indication. What are the contraindications for thrombolysis? So thrombolysis should not be considered if there are contraindications. So the main contraindication is if patient is presented after 4.5 hours, you don't have to write it as such because you have already mentioned that we don't consider it if it is more than 4.5 hours. After that, BP, because higher the BP, the risk of bleeding increases. Already thrombolytic agents increase the risk of bleeding, and if you have a higher BP, a blood vessel may rupture and bleed. And it's very catastrophic to have infarct and bleed in the same patient because treatment becomes a big mess, right? You try to treat an infarct with antiplatelets and all, then it will increase the bleeding. You give medications to suppress the bleeding, it will worsen the infarction. So it's a mess. So we don't want to have that. That's why we don't want to consider thrombolysis if BP is more than 185 by 110 despite treatment. See, Sutapa, everything that we prescribe in modern medicine, at least we are very open that modern medicine is not absolutely side effect free. We are very true, right? We know that everything, including paracetamol, forget paracetamol, even excessive drinking of water can be life threatening. So there's nothing called absolute safe. So the drugs that we are giving for thrombolysis, like retiplase, alteplase, tenecteplase, they carry very high risk of causing bleed. So we are sitting on a very high risk, but we are ready to take that risk when the benefits of treatment are more than the risk. So we see that the risk benefit ratio is favoring benefits more than risk for up to 4.5 hours. But after 4.5 hours, the risk of bleeding goes on increasing, the benefit goes on decreasing. Because see, with time, the number of neurons that we can save is decreasing. Because already most of the neurons are dead after 4.5 hours, 5 hours, 6 hours, 7 hours. The number of dead neurons is high. The number of neurons we can save is less. So to save that very tiny amount of neurons, we are taking a very big risk of giving highly risky drugs. So we don't want to do that. We always want to use a drug only when the benefits outweigh the risk. Just for you to understand, right? Let me give you an example. So if you want to be generally fit, there are some well-proven interventions, like you do some exercise, you eat healthy food, and you get 7 to 8 hours of sleep. This will definitely make you fit, and none of them carry any additional risk, right? Eating healthy doesn't carry risk. Sleeping 7 to 8 hours doesn't carry risk. Now you may say, sir, sleeping 7 to 8 hours carries a risk of failing in the exam. That's a different story. But from when it comes to health, it doesn't carry a risk. Doing a appropriate exercise regimen doesn't carry a risk. So they're all healthy. So they're definitely benefits outweigh the risk. But if I tell you that you can look more fitter if I give you steroids, right? Now you know that you will look definitely more fitter if you start taking steroids compared to someone who doesn't take. But it comes with the risk of suppressing your own testosterone production, increasing the risk of left ventricular hypertrophy, cardiac arrhythmias, death, gynecomastia, all the problems. Now the risks definitely outweigh the benefits. So that's why we don't support the use of steroids, anabolic steroids, right? So we use only substances or treatment interventions when the benefits outweigh the risk. So when it comes to thrombolysis, benefits outweigh the risk up to 4.5 hours or maximum 6 hours. After that, the risk outweighs the benefit. That's why we don't do it. Okay. Other contraindications, high BP. Second one, if you have bleeding tendency or bleeding diathesis because of whatever reason, like you have hemophilia or something, or if you have recent major surgery, there may be sutures and anastomosis from which site the patient might start bleeding. If you give thrombolytic agent, then it is a contraindication. And if you have an infarct which is very large, involving more than 1/3 of MCA territory, and the last one is rapidly improving stroke. Why rapidly improving stroke is a contraindication? The reason is simple. If it is rapidly improving, it means it is improving spontaneously. So why you want to give a risky medication? Let it improve spontaneously, right? It may be turning out to be a TIA where within 24 hours patients make complete recovery. Basically, most cases of TIA, body's own thrombolytic mechanisms are activated. That is, the tissue plasminogen activator within the body activates the plasminogen, and the plasminogen becomes plasmin and starts breaking down the fibrin. So clot dissolution happens naturally. That's why TIA patients are recovering. So if it is happening naturally, why should I give an external risky drug? So rapidly improving deficits. So these are the contraindications for thrombolysis. What else you need to write about thrombolysis? We know what is the indication, what are contraindications. You should also know agents used for thrombolysis. What I can use for thrombolysis. Thrombolysis nowadays is also called as fibrinolysis. Thrombolysis is a vague term. Thrombus means clot, and clot contains platelets and fibrin. What are we actually dissolving here? We are not doing anything to platelets. We are dissolving the fibrin. And because we are dissolving the fibrin, we can also call it as fibrinolytics. So we use fibrinolytic agents. And most of these fibrinolytic agents are examples include recombinant tissue plasminogen activator, RTPA, alteplase, retiplase, and tenecteplase. These are the fibrinolytic agents that we use. How do they work? Most of them work as TPA analogs. All of these are tissue plasminogen activator analogs. Means they work same as TPA. And what naturally existing TPA actually does, once you have fibrin in the body, it gets cleared by plasmin, and plasmin exists in the inactive form called as plasminogen, that gets converted to plasmin by an enzyme called as tissue plasminogen activator, and this plasmin breaks down the fibrin. So this causes fibrinolysis. Plasmin is responsible for breaking down the fibrin. In fact, more exact precise action is plasmin facilitates breakdown of fibrin to what we call as fibrin degradation product or FDPs. This is how the clot gets broken down. So all these drugs, they act like TPA, convert naturally existing plasminogen to plasmin, and our own plasmin breaks down the clot. Okay. So this is what it is. Now they may also ask you to mention the dosing of RTPA. Recombinant tissue plasminogen activator is most commonly used, RTPA and alteplase, and they may ask you to mention the dose. So the dose is used is usually 0.9 milligrams per kg, and the max dose we use is 100 milligrams. So now tell me, if I have a 50 kg person, how much should be the total dose? So total dose for a 50 kg person, 0.9 milligram per kg. So for a 50 kg person, it will be 0.9 into 50, that will be 45 milligrams. For 100 kg, 90 milligrams. What about 150 kg? The max we use is 100 milligrams. So I can't give more than 100. If it is a 200 kg individual, of course, there won't be probably much 200 kg individuals. But if I will not give more than 100 milligrams. 100 milligram is the max, because calculated dose for a 200 kg person will be 180 milligram. We don't give that. We will be giving 100 only. So if they are less than 100 kg, whatever the calculated dose comes, if the calculated dose comes more than 100 milligrams, we will stick to 100 milligrams as maximum. Out of that total dose, we give 10% as bolus and remaining 90% as IV infusion over 1 hour. It's like we took example of a 50 kg person, right? So if the person is 50 kg, the total dose will be 50 into 0.9, that is 45 milligram. That is total dose. So out of that, how much bolus we will give? 4.5 milligrams. You can equate it to 5 milligrams we will give, like 10% of that. So 5 milligram I will give as initial push bolus. Remaining 40 milligrams or 40.5 milligrams I will give as infusion. So infusion will be 40.5 milligrams. Roughly it is like 40 milligrams we will give as infusion. That is how we do the thrombolysis, right? So that is one treatment. The other treatment that is available is mechanical thrombectomy. Mechanical thrombectomy. So we'll also write a little bit about mechanical thrombectomy. So what do we do in mechanical thrombectomy? We remove the clot mechanically by passing a catheter into the affected artery. Now this mechanical thrombectomy is not widely popular as the thrombolysis. There is a reason. The reason is mechanical thrombectomy is not possible for all the blocked blood vessels in the brain. Our wires cannot reach every blood vessel. Thrombolytic agents, once you give, it will reach every blood vessel. So I can dissolve a clot in any part of MCA, any part of ACA, any part of basilar artery, any part of posterior circulation, but I can't reach any part of the blood vessel with the current available guide wires or catheter technology. So that's why mechanical thrombectomy is done in acute ischemic strokes, ischemic stroke patients presenting up to 24 hours of onset, having large blood vessel occlusion. Large vessel occlusion. Only large blood vessels we can cannulate and remove the clot. And what blood vessels can be counted as large blood vessels? Internal carotid artery, the first part of middle cerebral artery called as M1 segment of MCA, and proximal ACA. So if there is a distal part of ACA, I can't reach there to remove the clot, or if it is M2, M3, M4 segment of MCA, my wires can't reach. So for all those patients, thrombolysis is the only treatment we can offer, that too up to 4.5 hours. Though mechanical thrombectomy can be done up to 24 hours, it can only be done if the block is in the internal carotid artery, first part of MCA or initial part of the ACA. Beyond that, it is not possible. So that's why if you are going for mechanical thrombectomy, you need to know where is the clot, right? And how do I get to know where is the clot? Only by doing the CT angio. That's why I said if it is an ischemic stroke and if you want to consider mechanical thrombectomy, you have to go for CT angiography and identify where is the clot, and based on that you can decide whether mechanical thrombectomy is feasible or not. So the best outcome of mechanical thrombectomy is possible when if patient is presented within 6 hours of onset and you do mechanical thrombectomy, you are able to save a larger number of neurons. After 6 hours, a large number of neurons are dead. So the chances of complete recovery is less. And then there is something called as National Institute of Health Stroke Severity Scale score, and on the CT scan also there is a scoring system called as aspects score. So when NIHSS score is more than or equal to 6 and aspect score is more than or equal to 6, you have a higher chances of getting benefits from the mechanical thrombectomy. These are all more of MCQ terms. If you can remember, write it. If not, it's fine. As long as you are mentioning that mechanical thrombectomy can be done if these blood vessels are occluded, it's more than enough for your prof exam. So we have two major treatments, mechanical thrombectomy and thrombolysis, right? Apart from that, you should also write about secondary prevention, because all this treatment will solve current problem. It will establish the blood flow to an area which was not getting the blood supply earlier. I can do mechanical thrombectomy up to 24 hours. If the clot is in a feasible blood vessel, I can do thrombolysis up to 4.5 hours. For anyone who presents beyond these time frames, these two treatments are not feasible. So in them, all we can do is prevent future episodes of stroke. This episode of stroke, nothing we can do except rehabilitation and physiotherapy. So how do I prevent future episode of ischemic stroke? So in the future, one of the blood vessel, atheromatous plaque will rupture, platelets will come and bind, fibrin will be formed, blood vessel will get blocked, and they will have a stroke. So can I prevent this event from happening? Yes. If I can lower the accumulation of cholesterol, the disease will progress slow. And one day, if cholesterol accumulates and the plaque ruptures, I can stop the platelets from coming and binding, right? So what I can do, I can give statins to lower the atheroma progression, plus I can give antiplatelets so that one day if the atheromatous plaque ruptures, there is no formation of platelet plug and further activation of the coagulation cascade. So this is what we generally do for the secondary prevention. Along with that, risk factor mitigation. If you smoke, we would definitely ask you to quit. If there is BP, we will try to control. If there is diabetes, we will try to control. And that's how we manage a case of stroke. So secondary prevention primarily refers to prevention of a disease once it has already occurred. Primary prevention refers to before the disease occurs. Like, okay, let us understand this prevention. It's kind of a repetition of PSM, but just for the understanding. So let us talk about the stroke itself. Okay, so we know that hypertension and diabetes are the risk factors for stroke. And these risk factors will eventually, like high lipid, dyslipidemia, these are risk factors for stroke. So these risk factors will eventually lead to development of stroke. And as long as risk factor persists, right, there will be further episodes of stroke. Means if I have diabetes, kidneys will get damaged, right? The neurons, the nephrons will keep dying. But if sugar is not controlled, more and more nephrons will die. So the kidney disease keeps progressing. Similarly, strokes can keep happening again and again. Multiple different blood vessels will get blocked. So this is the journey of this patient's disease process. Okay. Now, if I try to prevent dyslipidemia, diabetes, hypertension from leading to stroke, how can I prevent? By treating the risk factors, right? If I intervene at this risk factor level itself so that it does not progress, then it will be called as primary prevention. Means cholesterol is high, LDL is high, I gave statins. Diabetes, I gave AC inhibitors or ARBs, or for hypertension, for diabetes, let us say I gave insulin or SGLT2 inhibitors or whatever. I intervened at the risk factor level so that the stroke does not happen. It is primary prevention. But if a stroke has already happened, I now want to prevent future episodes, another stroke from happening. If I intervene here at this level so that another episode of stroke doesn't happen, it will be called as secondary prevention. Okay. And then what if I act before the risk factors emerge? The patient was healthy, but then he got a very bad lifestyle. He started eating junk, drinking, smoking, and then slowly he started developing cholesterol, sugar started going up, BP started going up, right? So we know that all of these are lifestyle disorders. But what if I intervene before he develops these risk factors? Like, okay, I catch hold of him. You're not a diabetic man, but your lifestyle is not good. You're not at hypertensive, you don't have cholesterol, but right now the way you're living your life, you're going towards it. Let me take control of it. So please start going to gym, start running, start eating healthy, start prioritizing sleep, so that you don't develop diabetes in future, you don't develop hypertension in future. Then what did I do? I stopped the risk factors from emerging, right? Risk factors are now prevented. This is called as primordial prevention. Primordial prevention refers to prevention at the level before the risk factors emerge. We will call it as primordial prevention. Now, what is this tertiary prevention? So I had a patient of stroke, right? So I don't want another episode of stroke. So I gave him statins and antiplatelet, that is secondary prevention. But the stroke might leave him disabled, right? He is hemiplegic, he can't move. So whatever support I do to rehabilitate him, it's like, okay, now he is hemiplegic, so I give him a stick so that this side is supported, or I will ask him to be on a wheelchair, right? Or I will give him physiotherapy so that he can mobilize himself a little bit. All these are rehabilitative efforts. So rehabilitation is called as tertiary prevention. So technically, I mean, at a very conceptual level, rehabilitation is not prevention. It is just helping you get back to the normalcy by support system. But we do consider it as prevention, so it is called as tertiary prevention. I hope you have a clarity about the prevention. Risk factors from coming up, that is primordial prevention. Once risk factor comes, disease from coming up, if you are blocking it, then it is primary prevention. Once a disease happens and the deficits created by disease are handled by rehabilitation, that is tertiary prevention. And once a disease happens and further episodes of disease are prevented, that is secondary prevention. So here, because stroke has happened and another episode of stroke is quite likely, we're trying to prevent it. So we will call it as secondary prevention, and we are achieving that secondary prevention by giving statins and antiplatelets, right? So that completes our discussion for today. Jessica, absolutely right. So it's like every disease, the best mode of prevention is primordial prevention, right? So it's like, it's again a humble request, because medical education itself is a risk factor for all these diseases, because the way we live, the way we sleep, the way we work, the kind of duty hours scheduled in your internship, during your residency, they're all pushing you towards diabetes, hypertension, dyslipidemia. Make sure you eat healthy, make sure you prioritize sleep. I know your duty hours, your exam pressures and all of that, but beyond that, whatever time you get, instead of doom scrolling, instead of spending on unnecessary social media interactions, spend it on a good quality sleep, spend the time on reaching out to the right food sources, so that you don't get all these troubles. Because once you're in this loop, right, the life is mess. Once you're diabetic, hypertensive, dyslipidemic, after that stroke, nephropathy, neuropathy, ischemic heart disease, one by one the problems start hitting you and the lifestyle gets shortened badly. And there are studies which show that the average lifespan of Indian doctors is 10 to 12 years lesser than general population. Despite having the medical knowledge, you live less, and people who don't know anything about it live 10 to 12 years longer. It's not because we don't know to manage diseases, right? We know the management of diseases, but we don't emphasize on prevention. So make sure you prioritize your own health. so that we don't get into this loop. So with that, I'll end today's session. In the next session, we will take up the other systems. One of you were requesting Alzheimer's and Parkinson's, so it's quite late night now. I will record a video. It will be of 30 to 40 minutes, and I'll share it on the YouTube, which will cover Parkinson's as well as Alzheimer's for your profits. Right. So that's it from me here. I'm leaving this sketch of prevention for your reference. I'll bracket it in a table and leave it so that you will have an idea about the levels of prevention as well. So I'll see you in the next class. Till then, have a good time. Good night. See you. Bye.